Good morning, Brianna. Are you on?
Yes.
Do you know if we're going to have a quorum? I don't see any other
We
manager.
should. I talked to everyone. I know
Oh,
Julie.
I see Dr. Bell just joined us, so I saw it.
Yeah, Cynthia should be on. Dr. Zamora.
Okay. We still got a minute. I just wanted to make sure at least I had a quorum, and I see Dr. Bell, so I appreciate that. Okay, good morning. I'm Shannon Jones. I serve as chair of the Eastern Travis County Central Health Subcommittee. It is now 11:30 a.m. As a quorum of the subcommittee is in attendance via video conferences, I would like to call to order the meeting of the Central Health Eastern Crescent Subcommittee.
Manager Jones, if I may, this is David Duncan. I apologize. We really need to wait until Manager Valadez joins because there are only two members on your subcommittee, you and her. And if we can get her on, then you actually do have a quorum. At the moment, you do not. One is not enough. So, Brianna, is it possible you could reach out to Cynthia?
Yes, I just messaged her.
Dr. Bell is a ex officio. Is he not a member?
She just joined us, so you're
Okay.
good.
Okay. Yeah.
Carry on. Sorry.
Okay. That's okay. That gives me a chance to rehearse what I didn't say right the first time. So, good morning. Today is August. Good morning. Today is August the 12th, 2020, and it is now 11:31. As a quorum of the subcommittee is in attendance via video conference, I would like to call to order the meeting of the Central Health Eastern Crescent Subcommittee. First item of business is public communication. We will receive public communication for both of the Eastern Crescent Subcommittee and the Strategic Planning Committee before we proceed to the subcommittee agenda. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 10 a.m. today. Ms. Cruz, did anyone register to make comments?
We did. We had one person registered. So with that, I'm going to run through.
One moment before you call upon them. I'm going to ask that all persons please mute your telephone when you're not speaking so that we can have clear communication. With that said, go ahead, Ms. Cruz.
Perfect. To be recognized to speak, you must request a speaking slot using our bilingual online form or by leaving a voicemail by 10 a.m. the day of the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are in English and Spanish. All speakers must be recognized by name and in the order their speaking request was received. Please keep your phone muted until you are called to speak. Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Once again, speakers will be muted at 3.5 minutes to ensure the efficiency of the meeting. Speakers may not donate their time to other speakers as a courtesy to others, and to be respectful of time constraints, please try to not repeat other speakers' comments. Depending on the number of speakers and the total time being spent in the public communication portion of the meeting, the board chair may, in her discretion, impose additional limits on time or comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. So at this time, I will call up our speaker for today, Ms. Sharonda Robinson. If you are on the line, please unmute yourself. Ms. Sharonda Robinson. I will try one last time. Ms. Sharonda Robinson, if you're on the line, you can unmute your line. Don't think she's on, Manager Jones.
Okay, well, if she's not there, we'll need to proceed on. We have a full agenda today, so we'll need to proceed on. If she comes back in, maybe we can reschedule her for the next time.
Perfect, and we can shoot her an email as well.
Yes, okay, thank you. Okay, we will now proceed to the subcommittee agenda. We have 5 items identified for the agenda today, members, and I want to make sure that we have enough, I'm sorry, we have 7 actual items. I want to make sure we have enough time. I understand our first item will be rather extensive, and so I'm going to ask for those who are particularly, as you go through the presentation, please try and limit or be concise as possible, as we only have an hour and we would like to get through all of these items as soon as possible. If you have questions, please ask them when we give you opportunity, but let's try and make them concise in order that we can get through the agenda in the limited amount of time we have. With that having been said, review and approve of the minutes of July the 8th, 2020 meeting of the Eastern Crescent Subcommittee. Do I have a motion to accept the minutes of the meeting of July the 8th, 2020? I have a motion from member Valadez. Is there a second? A second from Chairperson Greenberg. Thanks very much. Any discussion? Not hearing any. All in favor say aye or raise your hand. Are you voting in favor of this, Member Valadez? Okay. All opposed? Not seeing any. Okay. Any abstaining? Not seeing any. The motion carries. Okay, thank you. Second item is receive a status update on COVID-19 testing in the Eastern Crescent from Matt Baltazar. And Matt will be presenting. Matt, welcome, and the show is yours now.
Thank you, Chairman Jones, and I apologize that you're seeing just a black screen coming from the Kramer boardroom. We're having apparently some difficulties on getting camera up there, but thank you for having me, and I will make sure that I am concise in this presentation, but did want to share with you all quickly some of the ongoings with the continued community care and central health response to the COVID-19 pandemic. So what you have here is a map of the community care testing locations as well as the Austin Public Health testing locations. They're color coordinated by the type of testing, or excuse me, the method by which the testing is conducted. So the dark blue ones that you see there are going to be the walk-up locations. Those are primarily Austin Public Health sites. Then the teal greenish color that you see, those are drive-through locations that community care has. And so we've been in probably the last month and a half, we've been in very close contact with Austin Public Health, wanting to make sure that we're able to spread our resources out to cover the target population. So we're not on top of each other, we're not duplicating, but we really are able to maximize their resources as well as our resources in this testing response. One of the new additions that you see on there that I'll draw your attention to is the marker number 9. And that's a new site in southeast Travis County that'll be on Burleson Road. It's not up and running yet, but we hope to have that operational by the end of the month. We signed a lease. I believe it was yesterday is when that was finalized for that location. So some of the benefits, and Brown, if you'll go to the next slide, please. Some of the benefits of this, and we're pretty excited about the opportunity to move indoors. So this is an indoor drive-through testing site. What that allows us to do, and you can kind of see our rough schematic here of how we think that'll be operationalized. But what you'll see is at the bottom of that square, where you see the testing being conducted, is it'll allow our teams to be sheltered from the elements. So when it's 103 degrees, as it's projected to be today, or when we get cold or whether it gets rainy, we will still be able to continue operations and we won't be affected by the weather. So this is an exciting step forward for us in our ability to provide consistent coverage and not be limited by certain hours because we're having to juggle around heat and adverse weather. The other thing is we see this as a location that's conveniently located to 3 of what we are considering our target communities down in southeast Travis County. You've got great proximity to the Del Valley community as well as Montopolis and Dove Springs. And we had conversation with our community advisory committee, our Southeast Community Advisory Committee, to help us identify this as a location and the availability for folks to and convenience for folks to reach it moving forward. So again, we hope to bring this online in the next couple of weeks, and probably next time we give an update, we'll be talking about the operations that we're seeing there and the numbers that we're seeing in that testing location. Next slide, please. So I touched on with the map the different models that are out there for testing. I want to share with you 2 models that Community Care is conducting for your awareness. So one is the drive-through testing model. That's predominantly what we're seeing or what we are utilizing when looking at community-based testing. The reasons for that are what's outlined there. One, we see it as higher efficiency. We've tried kind of a hybrid model where people park and then they and they walk in. It really slows down our ability to move patients through in a timely manner. So when we're talking about increased demand, drive-through really allows us to move folks through efficiently, as well as it's a lower number of staff to operate. When we are talking about 200 tests that we're able to do a day through the drive-through, we're in the 7 to 10 staff member range. So really able to make sure that those staff are being utilized effectively and efficiently, and so we're not having to overstaff by going with a different model. The other 2 reasons that you see on there are more safety related. So physical distancing, anytime someone can stay in their car, they don't have to interact with other individuals, it's safer. It's not to say that testing being done in clinic is unsafe. By no means is that what I'm implying, but we just find that opportunities where you can reduce interactions between individuals, there's a much lower chance of contracting the virus. So safer for staff and safer for patients. And then what we also see is there's no kind of direct passing of items between the cars and the staff. So we may give them a sheet of paper to fill out to do pre-registration. They then can put it into a Ziploc bag, and then that Ziploc bag stays on the windshield of the car as they move through. And so really limiting, again, the interactions between patients and staff. Next slide, please. The second way that we are providing testing is by what we're calling drive up and walk up. And this is really aimed at community care patients. Now, if an individual walks up to one of our drive-through locations, we have the ability to serve them. We recognize that not everyone has a vehicle and access to a vehicle. And so we want to make sure that we're accommodating at those drive-through locations. So we have arrangements in order to have folks be able to be served that way. But what you see here as represented on this slide is really available to what we're doing for community care patients, specifically at our health centers. And so we're doing testing at any in-person visit if it warrants it, if they're displaying the symptoms that lead to potentially lead to a COVID diagnosis. We're doing testing in person in the clinics. But there are other instances where we have patients who call in, they've got a telephonic visit, And over the phone, they express fever, cough, shortness of breath, etc. What we're able to also do is to say, well, we want to go ahead and get you tested. Come to our health center location. And so we'll do the televisit, we'll wrap that up, and then we'll have them come by our health centers and think of it as almost like a curbside where they pull up into a assigned spot where we can come out, we can verify their identity and deliver the test there without them having to get out of their car. Also, if they don't have access to the vehicle, and so the curbside method is not the preferred method, they're able to walk up as well and receive that service. So, and the next slide shows a picture of what that kind of curbside. I know we've all probably got good experience with curbside now, but if you go to the next slide, it's just another example of what that looks like at our different testing locations. So those are the different methods. I know that Austin Public Health, with their walk-up, they're doing it a little differently. And I believe even with some of their sites that are being run by TDEM, Texas Department of Emergency Management, I think there's another model that is being done there that is more walk-up based, where individuals are self-swabbing. But I believe we've got potentially someone on the line from the APH who can probably speak more clearly to what that model looks like. The next slide is, I also wanted to make sure I'm giving you guys an update on what we're seeing with community care. So this is a screenshot from our dashboard. I can dive into it if there are specific questions that come up. But what you're seeing is our overall positivity rate. It continues to climb, but on the left side, when you see percent positivity rate for the last 5 weeks, the encouraging sign there is that we are seeing that positivity on a week-by-week basis start to drop. So our overall positivity is still going up since March, but what you see on a week-by-week basis, where we were 5 weeks ago, where we had an overall positivity rate of 41% and then 42%, we're now seeing that drop week over week. And so that's a good sign of what we are seeing at our testing facilities, as well as that trend is continuing. Again, these are very high positivity rates, so I don't want to represent that that they're not, but these are starting to move in the right direction. And then when we look at it by ethnicity, you can see at the bottom there, the Latino ethnicity is continuing to drop week over week. This trend also holds true for our African American population. The positivity rate is continuing to drop in the same pattern that you see with Latino. On the right side with the map, the size of the circle, the size of the bubble that you see in the various zip codes, that represents number of tests provided, not necessarily positivity rate, but total number of tests provided. So you can get on a volume basis, where are the majority of our folks living who are accessing our testing facilities. And so you can see the Runberg area, as well as Colony Park, Dove Springs, and Montopolis are the 4 biggest circles that you see on that map. So with that, I think that concludes my portion of the update. And Perla, I don't know if there are others who will be presenting on this specific agenda item, or if this is a time for questions.
This is the time for questions.
Yeah, let's take questions now, because this is the only item I have related to that now, Matt. So are there any questions? If you raised your hands, I see Member Valadez. Do I see others? Okay, Member Valadez.
Very, very quickly on that testing site. I was clicking on the red dots and couldn't access anything. So I just wondered if what that was there for. With respect to the new testing sites, is that going to include outreach? Is there going to be an outreach expense? And if so, do we have a cost for that?
There will be quite a bit of outreach that'll be done related to that site. We really want to raise awareness of we will be waiting until we have a firm date before we really push it hard. There'll be a press release, as well as other avenues, and Yvonne, I see that you're on as well. But we'll be really pushing it through our community health workers that we have in the area, as well as through our contact information for our patients. But there'll be multiple avenues that are explored to get the word out, because this will be a site that it will be on 5 days a week, and we do expect we'll have a capacity of 200 a day. So it'll have the capacity to do quite a bit, and we want to make sure that folks are aware of it.
Are we going to have any sites that are open on Saturday and Sunday?
Our Hancock location is open on Saturdays currently. We are playing with the idea of looking at doing 6 days a week at this new Burleson location, but that'll involve a few tweaks on the staffing front. So right now we're committing to Monday through Friday, but looking at how would we adjust hours to get to weekends and potentially evenings as well.
The only reason I ask that is because within the Latino community, especially since we have the 49%, almost 50% positivity rate, and many of those are essential workers. They work 6 days a week. Some of them work 7 days a week, and they are very often unable to get tested during the week and on Saturdays. So I was just hoping if there was maybe in the southeast area or central location where they could go on a Sunday, at least even within a certain number of hours. I would like for y'all to consider that.
Very good point, and something we will absolutely take under consideration.
They're the ones that are going back into our communities and infecting others if they do have access to it. Can I ask a question on something else that was included in item 2 with respect to EPIC?
With respect to what, I'm sorry, Manager?
EPIC, the EPIC implementation.
Okay, if you make it short, or we're getting short on time, but yeah, go ahead and make it quick.
It's going to be with respect to EPIC. I knew that at one time I had heard that they were having a problem in meeting the High-Tech Act requirements, but I thought that they were going to do some work on that to see that they would, because there was a problem with the interconnectivity with other clinics and billing systems. I want to make sure that they fix that before we really look at it, or at least ask them about that. Also, they had let they made thousands of their employees work within the workspace. They did not let them work from home. And I was concerned about that. So this is a company that we're going to be working with, and I want to make sure that they are taking care of their employees. Otherwise, and that they overcame the connectivity issue.
Okay, thanks, Manager. I think Mr. Geisler wants to respond to that. Mr. Geisler?
Yes, sir. Thank you, Mr. Chair. Chair Valdez, that's probably off topic on this particular agenda item.
Okay.
But we can certainly come back around to that in future discussions around the EPIC implementation. We'll bring it back to the board. But your concerns have been duly noted.
I appreciate that. Thank you very much.
Thanks, Mr. Geisler, because I didn't quite understand the ramifications. So you'll get back with her. Okay, any other questions? I have a couple of quick ones, but I want to give other managers an opportunity. I don't see any other ones. So I just have a couple of quick questions. One, on the item of drive-through versus walk-up. I understand is Cassie Daly on the call still? From Austin Public Health? Thought I saw her earlier. But maybe you can answer this.
I am on call.
Oh, well, good. How are you doing, Cassie? Long time no talk.
I'm very good, Mr. Jones. It's good to be able to join y'all today.
Yeah, thank you. I have a question with regards to drive up versus walk through. I noticed that we have APH tends to have these drive up and walk up clinics. Could you explain what those are? And I understand particularly in Pflugerville, you have one. And why is it that we're doing the the drive up, get out of your car, walk up, versus just a drive through in those locations? Isn't it more efficient to do the drive through?
Sure, that's a really good question. So, when we initially launched testing, our drive-through site was the only location that we launched, was the St. John's drive-through location. And as we assessed the response and the ongoing testing needs, there was a need to be more amenable to public needs to have access to testing that for those who don't have vehicles. And so the community-based sites that we've launched in 78744, 78721, and out in Little Walnut Creek, those were really intended for people, of course, who have cars and could access, but also for those who don't have any other access, would need to use the bus, might have to have someone drop them off, or maybe, physically actually walking or biking to those locations. And so that was that intent, to try to provide a different option for the individuals who don't have cars. The other piece about the drive-through location is that it is hot, and people will sit in those vehicles for some period of time. And it's very efficient. We can get people through very quickly. But as we saw within Austin Public Health at our site, I know that Central Health Community Care also saw in their site, people would line up and they'd see it and sit in those vehicles for quite some time. And some folks, their vehicles really aren't equipped to sit and idle for some time. And so really having the walk-up option helps to better facilitate that. We've also seen, because it is resource intensive to do a drive-up site, and the weather is a concern, we've seen if there's an indoor capacity where we can bring people in and safely have them come in, that is more amenable particularly for individuals who, for sites where we need to have an indoor location where people are in the full hot zone with their full PPE regalia on. So those are the reasons why we wanted to give multiple options. One, to deliver that service, to be really more amenable for our patients that are seeking the service, so that they could choose whether or not it met their needs for walk-up or for drive-through.
Okay, that's very helpful, and I get that. I guess particularly, I'm looking at the Pflugerville location. My understanding is currently there is no drive-through location there. There is a walk-up that the city of Austin is working on or is contracted, and we also provided for clients of Central Health. So if you are a citizen of Pflugerville or in that area, you want to drive through and not get out and be exposed perhaps to others, is there a location in that Pflugerville area, 78660?
So right now, we've, Central Health Community Care was previously in Pflugerville, and we were able to, as that site had to demobilize, we were able to secure state resources to come in through, a STAR request, and to bring in it's a state contracted entity called Davico that is providing that resource to Pflugerville. It's not drive-through, and that's not how the state setup is for that location. So at this point, for those Pflugerville residents, if they need a drive-through location, they would need to come into possibly St. John's or maybe one of the other community care sites that are offering drive-through. But right now, in the Pflugerville location, that is the only site. Noting, it's got the Pflugerville bill, so ideally, it potentially could pose itself as that. It's just not that that contractor really isn't outfitted for drive-through.
And the only reason I raised it because several residents out there said, Pflugerville is the second largest community in Travis County. Why they do not have a drive-through for those who are, and these are suburbanites for the most part, so they're accustomed to being in their cars and taking action. So I would encourage you all perhaps to consider at some point if you can make that Pville location a drive-through at some point. I think it would be very beneficial for the citizens of the second largest community in Travis County.
Yeah, thank you, Mr. Jones. That's definitely a consideration, and we are always assessing how we can better improve our testing strategy, and agree that that's something I'll take back to our testing team to identify what kind of options we have. And we know that all of our COVID strategies are, evolving as the needs arise or whatnot, and definitely the drive-through option seems to be very much, there are certain populations that really prefer that, and we want to make sure that that's available. So I'll take that back to the testing group, and we'll definitely consider how that can be supported in our overall testing plan.
Okay, thanks very much. And my last question is for Mr. Baltazar again. I think you had the positivity rates listed for the community are going down. The Latinx community we know has the highest, and it's good to see those numbers are going down, and they continue to be the highest, and that is disconcerting. But for the African American, I didn't see those numbers. You posted them for the Latino. Do you have them available, the African American?
I do. It's given that was a screenshot from the dashboard, I couldn't be dynamic in that. But
well, you don't have to interrupt yourself now to do it. Could you just send them to me offline? I'd just be interested in seeing them.
Sure, and I'll relay them verbally here real quickly. For the week of July 12th, it was at 22.5. The next week down to 15.8, 16.1, and then for last week 9.1. And there's still tests to be returned from last week. So that's not a final number yet, but I'll send them to you.
Okay, thanks very much. I appreciate that. Okay, any other questions for this item? I'm not seeing any. Okay, thanks very much. Let's go on to our next item. There's no vote or anything necessary, motion necessary on this one. Item number 3, discuss and provide direction on process for healthcare delivery planning and community engagement for interim and long-term facilities in the Eastern Crescent. Ms. Stephanie McDonald and Ms. Rachel Audrey.
Thank you, Manager Jones. Managers, we have been working this summer to look at the data of both our patient population as well as the larger Colony Park community. And Rachel is going to make a recommendation to you all for your consideration. Pending your discussion today, we will take this recommendation to our clinical operator, Community Care, have them review and analyze their data and see if it marries our recommendation. We will also go to the community simultaneously and get their input on the recommendation. All of this will help inform a building program and what clinical services and how much space and how they are laid out in a future permanent health center will look like. And I want to let you know that there's a lot of data sources. One of them will be coming later to you, to the Strategic Planning Committee. And we also have received some health risk assessment data from our community care patients. A lot of this work will also feed into the wellness programs that will be recommended for this site. But this specific recommendation is for the healthcare clinical services. And with that, I will let Rachel take it away.
Okay, great. Thank you. Good afternoon, everyone. Appreciate the opportunity to provide this update to you all today. This first slide, if you'll recall, this is our sort of workflow roadmap process for how we're establishing our service planning efforts as we're moving through. And I've highlighted here kind of where we are currently in the process, just to kind of give you an update in terms of where we are there. Next slide, please. So in terms of our update, the Healthcare Delivery Division, we've gone through an extensive review of internal and publicly available data sources and reports, including internal enrollment and utilization reports for the Central Health funded population. And as Stephanie mentioned, the 2020 Central Health demographic report that we'll learn a little bit more about later for the Central Health funded population, and also publicly available sources such as the UDS, Uniform Data System reports that are provided from HRSA for FQHC sites. Additionally, just to echo again, Stephanie's reference to health risk assessment data that we have gained access to late last week from our CUC partners, just to kind of evaluate various sort of social determinants and issues that populations may have in these various focus areas, which will also be helpful in the more immediate future for the resource center, but also for the other focus areas. And those types of elements included in the HRA include issues with obtaining medications, food or housing insecurity, transportation, various aspects that might be additional supporting information that would be helpful for our planning efforts. Next slide, please. So our summary of findings for the Colony Park focus area, there's a significant proportion of households as expected below the 200% FPL. Chronic disease prevalence is lower than Travis County rates in this area. And out of all of the focus areas we're looking at, the highest count of enrollees is in this area. However, system utilization is lower for the Central Health funded members or population. Overall, though, the health service penetration rates for uninsured and low-income populations, so this is everybody, Central Health and the general population, are very good. Next slide, please. So our recommendations based on this extensive review is to focus on primary care for adults with the potential to phase in additional services over time. These initial services include comprehensive primary care, integrated behavioral health care, and also pharmacy services. Other services we're still evaluating include mammography, adult dental, and telehealth for certain specialties. Next slide, please. These next few slides really go into a little bit more detail, which are included in the demographic report, and some elements, again, are pulled from UDS and other internal data sources. However, it drills down just a little bit more firmly into specific percentages based on the population. Again, 30% of the population is funded by Central Health. This is the highest count out of all the focus areas. The Latino residents is nearly double that of the Travis County rate. And again, chronic disease prevalence rates are lower than Travis County rates for all 8 disease categories analyzed. And we'll learn more about this again later as the demographic report is shared. Next slide. Utilization in this 78724 community or zip code, Colony Park, Travis County Healthcare District, CUC, is the primary healthcare program that serves this community, followed by Peoples and Lone Star Circle of Care. And in this community, utilization is the second lowest out of all of the focus areas. So this is something to kind of investigate a little bit more and understand in terms of our patient population. And then there's also internal data sources which indicate specific utilization by clinic for members of this population where they're seeking services. Next slide, please. And penetration rates, again, this is at a high level for based on UDS reporting. So this includes all patient categories, not just those patients who are funded by Central Health. And you'll see that uninsured residents, there's a high penetration rate. Most of them are being seen. Low income, a good proportion, 54% are being seen, and then broken down also into Medicaid and Medicare percentages there on the screen. Next slide, please. So our next steps, as Stephanie alluded to, is to engage with the community and share these findings and gain additional insight and from the community in order to inform our next steps. Also to request CUC or our clinical operator to kind of evaluate their own data, as there may be more specific data that may sort of support or inform our decisions moving forward, and to recommend their own service delivery sort of recommendations, and then to develop a financial model as well. Also to obtain feedback from the clinical operator and the community and incorporate all of that to inform our final service profile for this particular community or focus area. So I know that was really fast, a lot of information, but I know we have a full agenda. So with that, that's the end of my presentation or update. If there are any questions, be happy to entertain those at this time.
Yes, we can entertain about 1 or 2 questions. So are there any questions? Member Valadez is the only one I see who have a question. Member Valadez, go ahead.
Yes, sir. So in the interest of time, I do have a few questions. If you don't mind, I'm writing them down. If I can send them to you all so that we can get a response and maybe share them with the other board of managers. But I do have some questions, and I want us to move forward. Okay.
Thank you, Manager.
I want to thank y'all for the reports.
I appreciate it. Other questions or comments from managers? Not seeing any. Okay. There's no action necessary on this item. We'll go to item number 4. Discuss possible approaches to advance site development, design, and construction related to future health and wellness center and clinical sites, including within the communities of Hornsby Bend, Colony Park, and areas in southeast Travis County. CEO Giesland and Mr. Lamp will be presenting. Gentlemen, go ahead.
Yes, thank you, Mr. Chair. We'll tee this up, and then I'll hand it over to Stephen. But you heard about the program process that Rachel and Stephanie just discussed. Now I'm going to shift gears and look at the construction side of it. How do you house those programs? The key to understanding the direction that we're taking really are 2 terms. One is evolution and flexibility. One, we have evolving service and space needs with all the different providers as we're going through this process. And two, we need the flexibility to be able to adapt so that we can serve people in these communities that we're focused on. I think for all intents and purposes, we've nearing the end of our internal desktop work we can do in a disrupted business environment due to COVID. And we really need to engage with the communities as we start going out for RFPs or requests for proposals or requests for qualifications. And the primary difference being we either use somebody in our pool and we seek qualifications to be able to do what we need them to do and engage with the community, or we go out and get new providers or contractors through a request for proposal process. But nonetheless, however we get there, we need to start engaging with the community, and we need to let them know. My goal is through email communications later this month, here's how we're going to move forward. Lastly, and I'll hand this over to Stephen, I think when we think about flexibility and both going through the design process and then the construction process is using a core and shell approach. Sometimes I see those terms reversed, but essentially building it out so that the tenants can come in later on and finish out the spaces they need to finish out. And it allows for that evolution and flexibility that we talked about. So at this point, I'll turn it over to Stephen for more precise explanation. Thank you.
All right, good morning, afternoon for me, apologies, I got mixed up. Very briefly, I mean, Mr. Geeson's presentation depiction is accurate. We don't quite yet know what the final program would be. And by that, I mean, we don't quite know what all of the tenants will be. We don't know what all the medical or the wellness services might be within a different building. But if we can quantify the general scope of the building, we could advance this without knowing the final information. So the approach is typical to speculative construction. This would not be speculative because we know eventually the tenants will be going in there, or at least most of the tenants or the programs. But we basically approach it as we design a building for hypothetically a 50,000 square foot building. We know right now that we have 25,000 square feet of specific program requirements for health and wellness. We know there are associated partners that typically affiliate with Central Health, and there might be other partners or different uses within the space. So we don't go into detailed design for 100% of the building, meaning we don't design for all 50,000 square feet, but we can start detailed design for 25,000 square feet, the part that's known. And in the future, as we learn the final program requirements, then we can define basically the final space for those occupants. If we don't know anything at this point in time, but we know we want to do something, we can approach the entire project as, okay, yes, we're going to provide 50,000 square feet at that location. We will design it as a core and shell. So the core meaning common elements, elevators, stairs, public toilets, and the shell basically enclosing the building, and do it the site development. And as the additional information comes in, the more detailed information about tenant requirements is defined, sorry, mental blank there, then we can design specifically for the tenants, and then we can do the construction as basically a sequential thing. This is a very typical process. It is a way to start the overall development or design and construction process without risking much in terms of either time or additional cost. And I'll stop there.
Yes, sir. So, Mr. Chair, that concludes our formal remarks, and then we would scale this and apply it appropriately, whether you're talking about Colony Park, Southeast Travis County, Del Valley, or Hornsby Bend. But thank you all for letting us present. Again, we just wanted to raise the level of awareness. We're not asking for official action at this time.
Okay, thanks very much. Are there any questions? Managers? Manager Valadez.
Just a quick one. With respect to the build out of the complex, are we going to at some point in time take into consideration, of course, what the community wants, but over that, what the needs are based on what community care is telling us, the medical demographic, medical needs, and then prioritizing that over things that the other governmental entities can provide with respect to the social determinants of health.
Manager Valdez, you just, based on the program flow that you heard just prior to the
I missed part of it, but that's okay.
Yeah, mine and Stephen's conversation. So the short answer is yes, we're going to go back to the clinical partners. I think if there is a prioritization issue where all of a sudden we have space conflicts, then quite frankly, I would want to bring that back to this committee here to have that conversation. But I don't, we're going to proceed in such a way as best we can so that we don't have those kind of space conflicts. But suffice to say, just in full disclosure, in addition to clinical, we are hoping to have non-clinical services in there that do address social determinants of health or provide, we talked with Colony Park about other city services as well. Now, obviously, we got to be compensated for that in terms of the build out, the space use and so forth, but that's a little bit further on down the line.
Well, then we're going to look at that. I also, since we have an issue with behavioral and mental health issues in our communities of poverty that have not yet been addressed appropriately or adequately, I'd like to make sure that at some point we look at that model for integrating on-site with some maybe telemedicine, but mostly on-site, so that the patient and the professional are working together under and maybe with a primary doctor, so that they can follow them to make sure that these things are taken care of as they go in to visit the primary doctor, who's also going to be kind of on top of their mental health needs.
Okay,
yes,
our time is getting short. We only have 15 minutes and we have 2 other items. So I'm going to see if there are other people who have questions. I think Mr. Giesling, you can follow up with Manager Valadez on that. I appreciate it. Ms. McDonald, I saw your hand. Did you have something to respond to rather quickly?
I just wanted to say that was part of our recommendation, that integrated behavioral health model for Colony Park.
Okay.
All right, thanks very much. Okay, thanks very much. Let's go on to our item number 5. There's no action was required on the previous item. Receive an update on the staffing and relocation of the Resource Center for Baltimore Overton Elementary School to Barbara Jordan Elementary School. Ms. McDonald will be presenting, and I'm going to ask if you can try and keep it within 5 to 7 minutes. I'd appreciate it.
I'll be shorter than that. I put a backup memo into the packet. We had some concerns about the transition that were raised by AISD's contractor. I believe that those issues have been resolved, and we are working to relocate that modular to the Jordan campus. And we are in the active process of selecting a program manager with the community. And Yvonne, would you like to add anything to that?
Only that we've been working on the engagement process closely together with the community leaders to make sure that we're all aligned in terms of how the community will be included in the hiring process.
And we also, and Jana, I'm sorry, I didn't realize you were on the call, but we have also been able to recruit some of our MAP members. Jana?
Yes, hi managers. We've been able to recruit 4 MAP members who are going to be able to participate in the screening committee in the selection of the program manager for the Northeast Health Resource Center. And so we're looking forward to having those meetings with them. Yvonne and I have been working really hard to make the necessary accommodations so that they can fully participate. As some folks, a couple people don't have internet access, and so we want to make the necessary accommodations for them to be fully involved in the process and give their input on some of the community needs for this position. So that's our update as far as the community engagement in that process.
Special thanks to the Yvonne and Jana and the team. They've had to find a translator who actually does Zoom breakout rooms with these folks separately. It's really great.
Thanks so very much. Our last item, there's no action on that one, is to receive an update on the plan and land acquisition of the city track for the future Loyola Town Center. Mr. Giesling and Mr. Lamb.
Yes, in short, we are still awaiting the completion of the property valuation so that we can commence with negotiations and finalizing the purchase. And I'll ask Stephen to fill in any details if there's been any developments over the last 24, 48 hours.
No, you are correct. We did exchange communications briefly with the city this morning. We are looking to advance terms of a potential agreement, whether it's a ground lease or fee simple acquisition. From there, we'll be able to plug in the final numbers, but we're waiting on the final appraisal at this point in time.
Is that it, Mr. Geisler?
Yes, sir, it is. Thank you.
Okay, thank you. Any questions on that item? I just have one, and I know you can't give me an answer, but at least I'll ask it to see if you can ascertain. Do we have sort of some time parameters in which we hope to be able to get back to us on this, meaning 6 months, year? You know, I'm just being, just trying to get parameters in terms.
Right. We're somewhat subject to the timelines of the vendor that the city has selected for the appraisal, but it's my understanding that Stephen, and correct me on this, or Stephanie, I've seen a 10/1 date, meaning October 1, when we do have a final appraisal in at the latest. I do know that Stephen's asked for some type of preliminary or maybe even a draft so that we could get started on some of the work, especially as it relates to contracting and so forth. So that way we're not standing still. And the city's been all supportive of this. I don't see any issues there, but Stephen, if I left anything out or mischaracterized anything? And
no, that is correct. There was a slight delay in the survey that would support the appraisal, but we still anticipate that the work will be completed by the end of September. So we should be in, land values and serious discussions and at the start of October.
Okay, you raised a question that I did want to ask. In light of the contract or the new Tesla plant that will be coming off of 130 and land values being impacted, will that ultimately, even though it's not right on 130, it's relatively close to that. Do you envision any impact of that?
I don't really know, sir. The appraiser will probably consider that, but in real estate, there are always rumors of what's coming versus what reality exists. So it may be a factor. The appraisal, though, is not the final definitive agreement. That's basically establishing sort of a baseline for further discussions and refinements based on timing of what the city will do in terms of development, what infrastructure Central Health might have to, say, front. So there are multiple factors, but yes, it could be. There's great anticipation for Tesla in eastern and southeast Travis County.
I thought they'd already started moving some dirt, but that may have been just the neighbors. I'd be mistaken. But thanks very much. Just something to consider as a factor. Okay, are there any other questions? Not hearing any. Our last item is confirm the next Eastern Crescent Subcommittee meeting, date, time, and location. Managers, our next regularly scheduled Central Health Eastern Crescent Subcommittee meeting is tentatively scheduled for Wednesday, September the 9th, 2020 at 12 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas 78702, and or remotely by video conferencing, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I am ready to accept a motion for adjournment. Do I have a motion? I have a motion from Manager Valadez. Do I have a second? I have a second for a Chairperson Greenberg. All in favor? Any opposing? Any abstentions? Not hearing any, we stand adjourned. Manager Bell, Chairperson Bell, I'm giving you an additional 8 minutes.
Well, I don't know if I can take those 8 minutes because I
That's
think
right.
that can't
That is
start
correct.
12:30, right?
That is correct.
Okay. We can stand adjourned until 12:30.
All right, thank you.
Okay. Oh, Manager Valadez?
Is anybody having a sound issue, or is it just me?
No, I did hear something.
You see
I
that?
did hear something. Yeah.
I hear that. I'm not sure. That's somebody that's probably not muted.
That sound is blocking out words.
I'll check with IT to see if that's something they can fix at their end.
Okay, thank you. We'll stand adjourned until 12:30. Thank you.
Okay, I have 12:30 on my clock, so unless you tell me differently, David, I'm gonna go ahead. Good afternoon. Today is August the 12th, 2020, and it is 12:30 p.m. As a quorum of the committee is in attendance via our video conference, I'd like to call to order the meeting of the Central Health Strategic Planning Committee. The first item on our agenda is to review and approve the minutes of the July 8th meeting of the Strategic Planning Committee. Do I have a motion? I have a motion from Manager Valadez. Do I have a second? I have a second from Manager Jones. All in favor, raise your hand. Any opposed? Any abstaining? Motion carries. Agenda item number 2, discuss the proposed fiscal year 2021 strategic priority focus categories, ongoing COVID-19 response, and enhancing clinical programming and supporting transformational operational initiatives. Sarah Cook will be presenting, and Veronica Butron Camacho will be available for questions. Sarah?
Thanks, Chairman Bell. As you can tell from the date on this slide deck, these are slides from last month, and much of the information that's included in these slides has been presented at Budget and Finance and full board meetings since the last Strategic Planning Committee meeting in July. But we will still breeze through them and spend some time hearing from the Central Health Director of Medical Management, Veronica Butron Camacho, on the planned expansion of that team and the impact that we anticipate on our MAP members. So to kick off our conversation today, here's a review of the priorities that have been presented at Strategic Planning Committee meetings in June and subsequent board meetings in July. You've received many more recent updates than this slide indicates, but today I'll focus on what we can anticipate in our FY21 season for the ongoing COVID response, to the extent that we can anticipate anything concerning the pandemic. And then we'll talk a little bit about clinical programming and operational improvements focusing on medical management. Next slide, please. As you all know, as we all know, COVID is really testing our flexibility. And you've heard already from Matt Balthazar about the extraordinary work that community care has undertaken in the past few months. And you've heard from others about what Central Health has been doing. And we expect that much of this work will carry into FY21, and wanted to lay out a couple highlights. So first, as we look to expand our testing and respond to high areas of need, as we've heard around Burleson Road, we anticipate that a new testing site requires around $1 million just for the testing team, in addition to other ancillary services that each site may demand, and equipment and leases and so on. So our budget will have to reflect that reality. The second item, we see another effort that the communications team has undertaken. We've heard about the outreach to MAP patients in high incident zip codes. And we've just recently supplemented that with a new effort to contact community care's positive patients, those from zip codes that have really high prevalence of disease, and provide them with useful information about how to protect themselves, their households, and their community. And then we also follow up with persons that they may have been in close contact with. Essentially, it's a contact tracing program. And you'll be getting more detail on that program leading up to the August board meeting. I think in that packet, there'll be a substantial memo on that new program. We know that communications has taken a large part in supporting the public information campaigns needed. We anticipate that that work will continue. And then, operational and clinical adjustments have had to take place, including a big shift to telemedicine at community care. We discussed a couple months ago how patients have received that service, and while most patients have seemed delighted with it, it's been a significant change in how our largest partner delivers care. And we need to be able to support and help adjust to this, depending, of course, on the virus or the pattern and its impact on clinical care delivery. So again, this is just reminding us that this pandemic is requiring us to respond in new and different ways and to maintain flexibility. Forecasting the future is always difficult. And this is true, I think, now as in any time any of us can remember. So we're going to continue to be called on to be nimble and flexible and ready to address whatever the demands are on finances, staff, and others, so that we can respond as a community and keep folks safe and healthy. Next slide, please. So this slide serves as a reminder that the 5 priority areas that we looked at the outset of the presentation, that first slide, do function under the larger umbrella of systems planning. You've heard about this in June from Drs. Mullen and Dr. Schulze, and John and Monica, and I think we touched on it again in July. And there's the graphic that we saw back then, and it's your monthly reminder that we'll be talking about this for a while. And again, how much of our work in FY21 is under the systems umbrella. Next slide, please. These are the second and third updates for today, how we'll enhance clinical programming and how we support operational improvements that support the systems of care work. You already heard from John and Cynthia at July's meeting about the considerable specialty care enhancements we're planning for FY21. And today you're going to hear from Dr. Schulze after our presentation about how community care is going to expand its behavioral health capacity. And as we just discussed, community care has made an incredibly quick pivot to telemedicine to cope with COVID-related restrictions. We want to keep the best parts of that pivot and to support community care as it refines processes and expands offerings for those telehealth appointments. And then finally, this year we're exploring what a homeless medical respite program would look like. As you know, as we all do, the medical access program cares for a large number of those persons experiencing homelessness in Travis County. And we both observe and have been told that our continuum of care for those patients is not complete. We're missing that critical component of medical services, medical respite. And we're exploring the best ways to purpose build a program that will ease hospital discharges, encourage healing and recuperation, and promote our patients' health. And so we hope to determine and pilot our selected strategy in this coming fiscal year. Next slide, please. Okay, so this is our third and final priority area update today, and we can move through these quickly. We already discussed some elements of EPIC implementation at the Eastern Travis County meeting at 11:30, and there will certainly be many more updates to come. In June, at the June board meeting, you heard about the improvements to eligibility and enrollment, launching the dedicated in-house call center, and the great strides that have been made on the virtual application. And then what we'll spend the rest of our time talking about today is the medical management department. And that's Central Health's department that's staffed with clinicians, including doctors, nurses, social workers, community health workers. And these team members work every day to assist our sickest MAP members and support those who are chronically homeless, struggle with chronic conditions, or who need the additional supports that we can help provide to them. There are many elements in the medical management program, as you'll hear from Veronica in just a moment, but as we know, one critical point in a person's healthcare journey is transitions between points of care, especially relating to hospital discharges. And the medical management expansion will broaden our ability, Central Health's ability, to assess MAP members in multiple hospitals. The care teams that devote their time to real intensive medical management and case management will be expanded. And these are really neat. They're multidisciplinary teams, nurses, social workers, community health workers, who have these team members drawn from the community and who come to Central Health with deep, deep experience in many facets in our healthcare system. They don't simply come to Central Health really and learn from here, but we get richly experienced members who join these multidisciplinary teams. And in addition, in this planned expansion that you'll hear about for FY21, we're going to double our capacity to provide benefits enrollment assistance. This is the critical step to connect our MAP members to programs that they deserve, like SNAP, the SNAP program, Social Security payments, and even enrollment into Medicaid and Medicare. we've enrolled 45 MAP members into other comprehensive insurance programs in this year alone. And that's a massive amount of work that each patient takes, but we're assisting over 6 members per month into Medicaid, Medicare, other long-term insurance options. So this is a real comprehensive program that our medical management team provides. And now I'll turn it over to Veronica to talk in further depth about some of these functions and describe what this expansion can do for our MAP members. V?
Hi, thank you, Sarah. So as Sarah mentioned also, one of the things I want to mention is that with the expansion of our medical management program, we will be able to touch an additional 8,000 MAP enrollees. We also like to expand our capacity to reach out and assist more MAP members and other healthcare facilities. That includes our partner facilities. That also includes hospital facilities such as St. David's. There's also other programs in the community that rely heavily on our department to help them navigate some of the most complex patients within Travis County. So some of those that we look to are Austin Public Health, Integral Care. They all look to us sometimes as being the experts when it comes to navigating MAP patients. And we are very happy to be able to help them navigate these patients. We'll also be able to expand our bandwidth to enroll more patients, as Sarah mentioned, into other services that will provide our patients with longer term medical benefits that they are actually, such as Medicaid and Medicare. And as Sarah did mention, this is a very long process to walk a patient through. There's extensive medical documentation that's needed. And this past fiscal year, or this past fiscal year, we actually brought on a position called a resource eligibility social worker who is now devoted and allocated just to our members that are that qualify for these sort of medical benefits. Sometimes getting these benefits also, such as SSI and SSDI, will allow a patient to also get some additional income, which then can sometimes house patients. So that is something we work very hard on with our community partners as well, and making sure that we get patients in the right place where they need to be. This medical management expansion will also expand our presence in hospitals by ensuring that transitions of care are streamlined without barriers, yet also ensuring patients are connected to a medical home. With the addition of our transition of care staff in the hospital, they are able to touch the patients while they're in the emergency department or in the hospital. They're able to work with the case managers in the hospital and ensure that there is not any sort of fragmentation in care when the patient leaves the hospital. As many of you know, when patients enter into the hospital, there's just an abundant amount of information that is provided to them and their families. And sometimes our patients don't understand all of that. We are there to make sure we are with them every single step of the way so that nothing drops in their health care. Lastly, growing our department capacity also includes educating our patients on all of the services and programs MAP has to offer. Without our department, it's really hard to connect patients to a lot of the services that we provide. I think that we've done a great job in creating additional services for our patients, such as urgent care, hospice care, palliative care, outpatient physical therapy. But if patients and inpatient hospital staff don't know about those services, those patients don't get connected. And that's why they end up going back to the emergency department and having recurrent problems, which leads them back there. While case managing them into a better state of health and in many cases, a better quality of life. So we're really excited about the medical management expansion. I think that we'll be able to touch many, many more patients and enrollees. And that's all I have for now.
And Chairman Bell, before we hand it back to you, I do want to emphasize the point that Veronica made. You know, thinking back to that systems of care graphic that we've seen with the cogs and the wheels that we'll see every month, as we expand our systems of care, we need to ensure that not only data flows well between new services and new offices that we may be working with, but that patients themselves flow well. And I think that the medical management team has been really critical in ensuring that any new service line we bring on is available, appropriate, and frankly accommodates our patients well. So much of the success that we've had as we've expanded service lines in the past few years, can be attributed to the facilitation, the education, and the outreach that Veronica's team does. And so I think that as we're poised on this exciting work of understanding which system components we need to add, we need to ensure that those facilitators, those critical operational enhancements, are also available. And that's where the medical management team so often comes into play. So I think that it would be a nice complement to the larger work that we're doing. And then this last slide, just to remind us, we've got a lot going on, as you've heard. Some of the things that we've talked about today, that EPIC timeline, looking at late spring 2021, I still think that is relevant. I'm not exactly sure. I haven't gotten an update recently, but that was true in July. Eligibility and enrollment timeline, we talked about that expanded call center capacity. That'll start coming in October 2020. I believe there have been hires made for those positions. And then medical management that you just heard about, phase in that increase in capacity starting at the beginning of the next fiscal year. So without further ado, we hand it back to you, Charles Bell.
Thank you very much, Sarah, Veronica. I tell you, I'm excited about the medical management portion of your presentation. That I've seen it in work in a number of different areas, and it is amazing how that can improve health by just connecting people to the necessary healthcare system that they need to be in. So, but thank you for that excellent presentation. I saw Manager Valadez's hand. Do I see any others? Not at this time. Manager Valadez.
Okay, now I'm going to bring up the EPIC question, since it was not appropriate previously. So as I stated, for those of you that were not present, apparently there was some problems with EPIC originally when the city was trying to bring them in, and the issue was around their inability to satisfy the interconnectability and meaningful use requirements that the high-tech law was requiring. I know that they were trying to work on that. They were working on that. I don't know if they've completed it, but what that meant at the time was that it was there was a difficulty with interconnectability with clinical and billing software and with other companies. I want to know if that has been taken care of.
Maybe I can take.
It has been taken care of.
Good afternoon, Board of Managers, and thank you. Maybe I'll take first shot at that. When we did evaluate EPIC, one of the aspects that we were most excited about was the interconnectivity of the product itself, and that it really did speak to all aspects of the care model. One of which I'm going to present on in just a bit, but I'm not aware of what happened before, but it really seems like one of the most exciting aspects of the tool that we're looking to now.
Thank you. It was when the city was looking at it and challenging them. So I don't know after that whether or not it got taken care of. I just want to make sure it is taken care of for us. And that's not the only question I have.
Thanks, Manager Valadez. Mr. Giesman, please.
Yes, thank you. Manager Valadez, first of all, thank you for re-asking the question. It clarified it for me. But what we can do is circle back around with John Clark and others that are on the implementation. And actually the evaluation team, prior to even selecting or finally selecting EPIC, to see just from the diligence standpoint, did they run down any of these issues, or if they were even made aware of what the city's experience was, and to see if they're running into these things. But we can certainly follow up on that when we come back to do the budget presentation and start talking about some of these priorities.
Especially as it relates to clinical and billing software programs of the other entities. Yeah. Thank you very much. Let me just ask one more time with respect to the medical management timeline. About when do we see the full, you said it says October 2020 for implementing that medical management program? Changes?
Yes.
Great.
I think, yes.
Okay, then I'd like to make a suggestion as we're looking at that, as I have for prior to my being on the board and after being on the board. I have actually tried to go before the legislature asking them to change it so that it's required that when a baby is born in a hospital or elsewhere, that if we know that there's going to be a problem with that child's health, that we immediately counsel the parents to put them on, get them enrolled in the appropriate Medicaid program, and also the Medicaid waiver program, so that those children will grow up to adulthood if they do make it that far, and they'll be completely covered. Their needs will be completely covered. There are a lot of people that don't understand that, but I've had to deal with that through the birth of my child and through enrolling many other people in Social Security and having to deal with Medicaid and having to deal with the school system. And so when we deal with that, we look at trying to, if nothing else, the existing systems that we can try and incorporate into our system of care means dealing with entities such as Any Baby Can, who get the 3 and under population of children who have already exhibited major medical needs, tie them to the special education systems in all the school districts within Travis County, because it is their responsibility then to manage the care that those medically needy or psychologically needy or mental health care needy behavioral needs of those children are until they turn 22. Then they become adults and they come into our system of care. Many of them get dropped if they're not in a Medicaid waiver system that they have to be enrolled in by the time they're 18 or younger. And so that's where we begin to see kids dropping out of school. And I've seen them drop out because their medical needs were never identified fully while they were in the school system for mental health, behavioral health, et cetera, learning disabilities, et cetera. And so we need to work with the school system to make them more responsible. I'm happy that we have a new superintendent who is going to understand that population, and I'd like for us to be working with her directly as we plan this holistic system of care change. And then make sure that they get into, because the school system's social workers can also make sure that they get into Medicaid or Medicare systems, or MAP, if we tell them that's what we need for them to do, as they reach their year 18. Because at 18, they have already got to end up going through the probate court and end up being adults on their own, either deemed competent or incompetent, so that they can also be taken care of. A lot of parents don't understand that, but the sooner we access the systems that are already responsible for doing that, those are the adults that we don't have to be retroactively trying to get them into our systems. So this is something I really want us to pursue aggressively, because it'll save a lot of steps with respect to our, and alternatively, in trying to get them in the system after the fact. Okay, because special needs children grow into special needs adults, depending on the diagnosis. And Dr. Shawshak, you should understand that too. So Dr. Bell, if I can just make sure that we do that, because then we're going to hold accountable the systems that already exist, and not have to duplicate our services, which should reinforce and support whatever they're going to need when they come into the community. So if you needed more additional help, I'll help you with that. I feel like I'm an expert in handling all that as a community health worker and a parent of a special needs and a ex-wife of a man who I got on Medicaid and in a nursing home. So please, I'll do anything I can to help you all achieve this.
That's an excellent, excellent suggestion. I think that would be a real good exercise for medical management in dealing with those connections. And I have a feeling, I don't want to talk for Veronica or Sarah, but I have a feeling that that connection is probably something that's already on their list, but I'll let them speak to that.
I hope so, because as a parent of the school systems who has seen the transition be the worst managed transition system, let's say from elementary school to middle school, from middle school to high school, from high school to community, that's their least priority. And I would like for us to make it their most priority as central health advocates with the school system, 17 of which exist in Travis County.
Definitely, definitely. Sarah or Veronica, did you want to speak to that?
It's definitely one that's been on our list. And I think with this expansion, I can tell you, from experience that when you talk about patients that we have encountered patients usually through Dell Children's Medical Center that have aged out of the system. They end up in a very, very difficult situation. And we have had to work very closely with families and get very, very creative on how to get them everything that they need, from DME to care services. I mean, these are patients that have had full care for have had to care for their loved ones for a very long time. So we are very sensitive to that, and that is definitely something that is has been on our list. And I agree with you. Getting involved with the school systems and making those connections would definitely help these patients tremendously, because many times it's the social workers that we hear from in the hospital, and then they're the ones that reach out when they don't know what to do with these patients. So I think it's a great suggestion and definitely one on our list. And I think with the expansion of our medical management programs and the expertise that we have on our team, I think it's something that we will be able to work with.
I appreciate it, and I will be willing to talk to you about this at length, because I can tell you where the flaws are, where the gaps
Absolutely.
are.
Absolutely.
Thank you very much. Thank you, Veronica.
Uh-huh.
Any other questions from board members with regard to this particular item? Okay, seeing none, I will go to agenda item number 3, receive an update on Community Care's primary care behavioral health strategy. Dr. Alan Salsha will be presenting. Welcome, Dr. Salsha, and thank you for being with us.
Thank you, Chairman Bell and Strategic Planning Committee. It's a pleasure to be here and to share a little bit about why we're doing what we're doing. I think the goal moving forward, or the goal in this presentation, is really to share a little bit about the significance of the disease prevalence in our environment, why we need to create more access. We did receive some specific questions as to our transitioning relationship with integral care. It's been a rich one. It's going to continue to be a rich one, but we're transitioning some models of care within. And so I'll explain to that and really talk about kind of our previous state and developing state. If I can go to the next slide, please. So longitudinally, there's a significant need for behavioral health access within our environment. If you look at 2011, 20% of the U.S. really needed access. A couple years ago, as stated by HRSA, specifically the folks that we have been charged with advocating for, low-income individuals, those earning less than $35,000 a year, are at increased risk and are at about 5 times greater chance of experiencing kind of mental health stressors or suffering from mental health conditions. And so obviously exactly within our lane is where we need to increase that access. Next slide, please. Within Travis County, on a monthly basis, individuals experience 5 or more mental health stress days per month. And when you look at once again, the population that, who sit within our swim lane, those experiencing poverty, those experiencing or suffering from displacement or gentrification, those with immigration concerns, or those suffering racial or gender identity discrimination, they're at increased risk. And so once again, we need to do everything we can to expand our behavioral health presence. And when I'm referring to behavioral health, I'm speaking to behavioral health, which is more kind of behavioral modification, and then kind of mental health diagnoses as well. Of the 116,000 patients for who we cared for last year, we only administered a kind of mental health care to about 13% of that population. And so if you look on the conservative side, 20% of the folks within our scope need access to mental health. If we really want to consider what we need to create access to, it's more like 30 to 35% of the individuals within our care environment. Next slide, please. We've had a rich history with integral care, and ever since we were a part of the city. The Emerge program really began in 2007, and the purpose of the program was really to integrate behavioral health and primary care, both placing primary care providers within a mental health environment and vice versa. That program was grant funded, and those grant monies really allowed for personnel that helped transition individuals between the primary care environment and the mental health environment. At all times, the systems of care were independent, and so they were two separate electronic health record systems. Those monies have long since gone away, and I think for years and years and years, we've been trying to operate as though we had the infrastructure built to support a program that had good intent but is no longer funded. Over time, 3 of the 4 sites in which we had primary care presence within the behavioral health environment have transitioned, and 1 site is in transition now. I also do want to point out that I'm really speaking towards primary care, not including women's health and not including kind of Ryan White. We do have behavioral health individuals who advocate for patients within those environments. And so this is a very specific behavioral health and mental health kind of presentation or allocation. Next slide, please. As with our relationship with Integral Care, we had contracted for about 10 FTEs. Those FTEs used to conduct a method of care that was therapeutic based. And so that's when we think about a patient making an appointment, sitting with a behavioral health therapist for a new patient visit, maybe an hour, for a follow-up visit, and maybe 30 minutes. And so those were the stereotypical visits. We have been transitioning over time to kind of short, brief interventions. What we have found is that there's a ton of evidence that shows that if we have behavioral health individuals present in clinic when there is a need, we can directly connect the patient to that behavioral health expert and transition care. Much of the individuals that we advocate for, and I'll show some stats in just a bit, but many of the individuals who we advocate for really have challenges, more so in the primary care environment, related to their chronic conditions or acute conditions, and often seen barriers of care. So, they can't get better with their diagnosis of diabetes because either there's a lack of understanding, they're depressed, they can't afford it. And if we can bridge those initiatives by connecting them to resources who can move that initiative right away, we're much more likely to be successful. Now, the other thing that does is, we on the slide, it shows 73% of expected encounters were met. If we had agreed with Integral Care, the goal should be 10 visits per day. Now, as you transition models, right, the brief interventions are really 15-minute interventions. And if we look at, a day of an 8-hour day, let's say 6 hours of that day are really functional for visits, we should be able to see about 18 patients a day or so, anywhere from 12 to 15 to 18, and really move a ton of patients. And so, we did pretty well with our goals as related to Integral Care, and we really worked, closely with them. But our model is changing. With our telepsychiatrists, again, the goal had been 6 patients per day. We feel by concentrating on primary care initiatives and not severe mental illness, we should be able to see more patients. When you do have contracted services and you operate in 2 separate electronic health records, there are risks. There were times when we couldn't see medications that were written by one side or the other, and there was poor transition between the two. Again, we don't have personnel that can, handhold patients between mental health electronic health record system and a primary care mental health record system. And so our goals were really trying to bring those together. And I think that's what the Emerge program had originally aimed to do. Again, that it has just changed over time. There were also administrative costs because we were maintaining personnel in another, by way of another organization. And so when we internalize those individuals, we don't have to double those administrative costs, and we can reinvest those administrative costs in increasing the number of individuals, again, that sit in our environment and advocate for our patients. And obviously, there's a different culture or a model of care. We are really concentrating on a primary care model, on an ESPRIT model, on connecting the dots. And though we always want our patients to have access to therapy, the studies really show that chronic conditions and chronic disease really advance when you create these linkages. Next slide, please. And so just taking the positions that we had available, we're actually able to increase our scope by increasing the number of encounters because we've changed the model. The culture is our culture. The care model is our care model. The electronic health records are the same. The providers will be charting in a SOAP note-based format, and all provider teams will have access to the same medical health records. Next slide, please. Now, the care model that we're really transitioning to, and I provided some reference slides a little later, I won't go over every slide, is really a primary care behavioral health model. And this is really based on chronic conditions, on acute care, on curbside consults, so that if a provider comes out of a room and they need to touch base with a behavioral health consultant, there is no appointment made. That behavioral health consultant is called then and there. The behavioral health consultant, either remotely or in person, comes into the room, and there is a direct handoff with patient care so that the goals to care are advanced right then and there, and the behavioral health consultant can then follow up independently with the patient. If we look at the amount of time that providers are spending with patients, much of what they do is not based on the clinical care. It's based on the barriers to achieving success. And if we're able to conduct that handoff, we create access within a primary care environment because providers can actually see more patients and then hand off patients when appropriate to the behavioral health experts who really are experts in moving that care. So there is increased care. In addition, we're not talking about two separate entities. We're taking the stigma away about mental health, and it is just a patient-centered medical home. And within the patient-centered medical home, we advocate for all aspects of care. Next slide, please. So as we're moving in this direction over time, we've looked at the number of mental health diagnoses, and 75% of the diagnoses, let's say last year, were primary care based or associated with a chronic care condition. We need to collaborate with Integral Care. They're the mental health authority, and we're not skilled. We are not set up to function to care for folks with severe mental illness, and thus our partnership with them is critical as we move forward, because the 25% of the mental health conditions that should not live in a primary care environment, we need partnership. We need access for those patients to have their care governed. Next slide, please. Again, this slide really speaks to what I was talking about, and specifically when we look at the quadruple aim. So are patients more satisfied with their care? And the studies show with this model, yes, they are. Is the quality of care actually improving? And once again, we can check that box. Are we decreasing costs? We can check that box. And then what is the thought of the care teams? How do care teams feel about the ESPRIT model versus more of the classical model? And the studies show that the care teams feel much more favorably when you have a person that you can do a direct handoff and move the care right then and there. Next slide, please. Again, we're going to be focusing on prevention, on treatment of acute and chronic conditions, on symptom reduction, functional improvement, and then ultimately better quality of life as deemed important by quality metrics, but more importantly, by the patients themselves. Okay, next slide, please. I'm not going to go through this item by item, but this really shows the primary care-based model versus the collaborative care-based model. The collaborative care-based model, we will always have an aspect of that, and that is setting your appointments, working with a mental health condition, not necessarily embedding mental health within primary care for those short interventions. And so you can see the differences. We are really going to strive, the primary care behavioral health model, and actually have been working on that for the past 2 years. So right now, our makeup is mixed. We have 50% Esprit and 50% more of the traditional model, and we're going to be moving even more to the Esprit model. Okay, next slide, please. And this is really just wrapping up. Our care teams need to be available for curbside consults. There may be some appointments that would be on the schedule, and so it'll be a mix. But we have our team. We really need our teams to be available. If you look at the numbers, if you have a really well-refined model, one behavioral health therapist could care for about 3,300 to 3,500 patients over the course of the year. And if we look at a primary care, if our panels stay the same, about 1,250 patients assigned to every primary care provider, it's between 2 and 3 primary care providers that a behavioral health provider should staff in order to, again, advance the care for those primary care providers. Next slide, please. And I think that is it. And I will turn it over to Chairperson Bell. Thank you very much.
Thank you, Dr. Salsha. I really appreciate it. Great presentation. I know that that model has been worked on a lot of different ways and many different times. So it seems like you're getting ready to perfect it, and we hope so, that's for sure. Any questions? Okay, I see Manager Valadez and Manager Musaitif. Manager Musaitif, you go first.
Thank you. Can you hear me?
Yes, we can.
Well, thank you, everyone, and thank you, Dr. Shelsa. My first question is, acting CMO?
I'm not sure what to say about that one. Yeah.
So that caught my attention. And how are we dealing with the shortages of mental health providers, and how are you able to supplement that? So I think it is an issue all across the nation, not just here in Texas. Just wanted to get your input. And another thing, can you elaborate more about your curbside consults? How does that look like? And is e-consult embedded into this network? Thank you.
Great questions. The shortage of providers, knock on wood, we've been relatively fortunate in transitioning and bringing on new behavioral health therapists. I think as far as needing to gain access to patients or creating access for patients, by changing our model a little bit, even with the same number of behavioral health therapists, we're able to create more access. And so that was one of the points. We created greater efficiency by making this transition, and so we can create the opportunity to hire more individuals. Austin is a very sought after environment or city to live in, and so I think it's a competitive environment and people want to move here. And so as of now, and again, I'm going to knock on wood again, we have a good applicant pool and have been moving to really fill vacant positions and have not sat with open positions for a very long period of time. And so we hope to continue that. As far as the curbside model, it just means that the behavioral health specialist needs to be available. So he or she needs to be in close proximity to the care team, to where a member of the team can knock on the door or send a message in order to do a direct handoff. The studies show that if the providers directly introduce the patient to the behavioral health specialist, there is a much greater chance of a successful follow-up. And so that handoff is made in person or virtually. And then e-consult or e-visits, electronic or e-consults are absolutely, they're part of our current model, and we'll continue to advance that.
One thing I just want to emphasize is the relationship that matters in cultural competencies within the handoffs and providers. So to take that into account when we are training our physicians, because we are working with unique subpopulations, that we are mindful and vigilant of their backgrounds.
No, thank you for that. Thank you for that comment. And I think one of the greatest, or one of the things that happens through this model is physicians learn. They're working with a specialty group that many of them have not worked with before. And so the education process is both for the patient and for the provider. And so as patients are cared for and those exchanges are made, it's shown that, as with e-consults, the provider's educational level and behavioral health prowess actually increase, and hopefully in sensitivity as well to some of the, the environments, that you touched on. And just to clarify on the acting CMO, just helping out on the central health side, hopefully still as far as CUC goes, I'm still their CMO unless somebody tells me otherwise.
Thank you, Dr. Shalsha. I was going to try to field that question, but you answered it beautifully. I appreciate that. Manager Valadez?
Very quickly, I'm going to give you all a very quick story. When I was part of the AISD student population, especially special education student population, we had a problem because I'm an advocate for parents who have bilingual special ed students. So they have to hit the bilingual education component and they have to hit the special education component when they're dealing with the ARDS, which is your acceptance of a student into special education, where you are covered for all services and therapies, etc. We got to a point in dealing with the special education department at AISD that found that the diagnosticians appeared to be the biggest problem. We did a study and requested an open records request from AISD and found that all the kids in special education that were accessing one-on-one services, most everyone lived west of 35. Hello, does that sound familiar? West of 35, the diagnosticians were giving the children in the elementary schools or the middle schools or the high schools the diagnosis of autism. And east of 35, they were giving them the diagnosis of ED, emotionally disturbed. So as the emotionally disturbed students did not get the wraparound services that autistic students are legislatively now required to receive, that left all our children living east of 35 in the Eastern Crescent wanting and lacking of services. This is a fact. It is not made up. It's a fact. So that goes to the whole mental health racist, systemic issue that we're having to deal with. So it's the care manager over the children who have these issues under the auspices of Integral Care, which used to be the old MHMR. I've been with MHMR since my daughter was born. So I know the case manager role is very important, but case managers don't always have access. Like the physicians, they're learning what the diagnoses mean or the lack of a diagnosis means for the children that we are talking about right now that grow into adults or drop out of school and because they didn't receive appropriate services. And so the primary care physician is a great resource for the parents and for the students following a child who is on the case management roles of IC because they are still in elementary school, middle school, or high school. They haven't been released at 22. So it's important that we understand that the systemic change that needs to occur with Integral Care, understanding that the people that they hire to address the needs of these children who are still in the school district's area of responsibility, that they actually have people who are language and culturally appropriate. Thank you, Maram, for bringing that up, but it's language and culturally appropriate because 90% of the time, you will find that the case managers dealing with the children that are in special education roles are English-only speakers. And so that there is a difficulty in transitioning and teaching the parent what are the appropriate strategies that they need to do or utilize with their children, okay? So that they don't grow into school dropouts on the streets, murdered by gangs, getting involved with the wrong people, not making good decisions, and becoming people homeless or on the streets because they didn't get the supports they needed when they were in school. I've seen too many children die and too many children get killed and make wrong decisions because they didn't get the supports from the public school system that was supposed to provide them. So again, This is a tie, an essential gap closer that we need to talk about and implement with Integral Care, which is the state required entity to talk about or address the needs of our children that grow into adults. Okay, so this is where a big fix can occur relatively easily if people will just be responsible in a cultural and a language way. If the diagnosticians in the school systems understand the differences between autism, there's 250 in the spectrum, and emotionally disturbed, because they are acting out the issues of gentrification, of joblessness, of homelessness, of poverty. And this, again, the literacy component, the health and medical term literacy component can happen from the time a child is diagnosed with the parent through, again, the system that is being going to be implemented by Central Health and Community Care. But we cannot exclude Integral Care in understanding that there is a language and cultural barrier that exists with their case managers and these children that grow into adults on the street. And I, again, would like to talk to them about that too. Thank you.
Thank you. I appreciate that, Manager Valadez. Anyone else with any comments or questions or concerns? Okay, seeing none, I would like to bring, thank you, Dr. Salsa, that was great. I appreciate the presentation and look forward to hearing about the success of that model. Thank you. Agenda item number 4 is to receive the second and final update on the FY 2020 Central Health Demographics Report, which includes additional information on families living in poverty by census tract, enrollment, burden of disease, and projections through 2025. Members, this item is going to take a bit, so I don't know if you want to wait and take a break in between, or let's just see how it goes. We're at about 1:20 now, and so I had a slight preview of this, and it was about an hour, so, and that was a brief preview. So I expect this to probably go on for an hour and a half. It's great information. I think the information that you will glean from this report is most interesting, and I think it will help us to look at how we spend our resources in the future. I think we're spending our resources appropriately right now, but we can't just think about today. We have to think about tomorrow and even further. And this puts some light on that situation. So I think that Manager Valadez, you are muted.
I have a question and an ask that I have previously asked for and not received, and that was a utilization report from Community Care, because I think that will help us as a board understand the decisions that they have to make with respect to closures and siting of new clinics, and also what services to provide there. But I would like to see one. I haven't seen one yet. Utilization.
Okay. We'll take note of that, Mike. I think Jason is here. So Jason, if you would take note of that and provide that information to Manager Valadez, I appreciate it. Okay. The presenters, I think Monica Crowley will kick this off, but we have J.P. Eichmiller, Sarita Karklich, and Dr. Alan Chalsha, who will be presenting and available for questions. Monica, I'll turn it over to you.
So thank you, managers. This is the second presentation on the fiscal year 2020 demographics report. This is the third iteration of this report, and I just would like to note that the depth of information and the focus on the patients that we serve and the health of the communities that we serve and the patients has become a deeper part of this report with every iteration. And there was a memo that went out in the backup, but one of the key things out of that memo is we have better data than we had in the past, and we're able to look at the census tract level instead of the zip code level, which also gives us an ability to focus in on the communities that are the focus areas of families that are experiencing poverty in a way that we hadn't in previous iterations of this report. And this also adds a level of information about the burden of disease in 8 disease areas that I think is going to be part of these demographic reports well, not year over year, but every couple of years when we do the updates, that we'll be able to track over time the impact of the decisions that we make and of the policy and planning decisions that you guys make and support for Central Health. And I just would like to thank JP Eichmiller and Sarita Clark-Leach and Ashley Leviolette, particularly and all of the other people on their teams that I'm forgetting right now, for all of the months and months and months of hard work that they've put into developing this information. And this is, I'm really excited to hand it off. And there will be, once the final document, which JP can tell you how long it is a very, in-depth, detailed, big report. And JP and Sarita and Ashley will be available for one-on-one meetings with you guys, for meetings with elected officials and their staff, or for people with different communities of interest or stakeholders. This is something that the last demographic report, JP actually kind of went around town handing out reports and talking to stakeholders and people in the communities, building relationships that I think that have been useful for all of us over time. So I hope that we also can, the team can build on that even in this COVID environment. So I'm going to hand it off to JP now.
Hi, thank you. Can you all hear me?
Yeah, JP,
okay.
We can. Thanks.
Great. I am going to share my screen now. And okay. Can you all see the full screen view?
I can.
All right, great. Thank you for that introduction, Monica. I wanted to echo everything you said. Thank you to everyone, Ashley, Jesse, Sarita, and your team. It's been incredible working with them for months and months to get us to this point. And also like to thank Monica. She's been the executive lead and sponsor on this, and she's really pushed us to go further in some exciting new directions. So yeah, we're really happy to be here today presenting this to you. And as Monica said, this is just the presentation, the findings. The actual report itself, I believe we're up to about 72 pages. So hopefully I'll have some good reading time scheduled ahead of you. You can really dig into this data. So a little background, we presented our first demographic report in 2015. That report focused on families in poverty, as well as racial demographics throughout Travis County neighborhoods. The report was limited, however, in that we didn't incorporate any of our patient level data. In 2017, we presented our second report. In that report, we began to focus on specific neighborhoods that were experiencing high levels of poverty. We identified 9 focus areas, and we provided demographic analysis, as well as some measurements related to social determinants. We also, for the first time, presented some patient-level data related to the diagnosis and treatment of chronic conditions. In 2020, our ability to analyze and report data has grown exponentially, and that's represented in this report. As you'll see, we are now able to provide much deeper analysis in our previous reports, including new data points detailing the burden of disease within specific Travis County neighborhoods. Before we begin discussing the report, we wanted to offer this slide as a reminder of the system-wide approach Central Health is taking with its planning efforts. The demographic report is really meant to serve as a tool in piecing all these separate cogs together. For example, a better understanding of the trends in poverty and utilization can help us better plan for where and what level we want to stand up services. And we're creating baselines of disease prevalence, which will allow us to measure the success of our interventions in the future. We're developing a better understanding of how our outreach and enrollment efforts also affect how we capture and treat new patients. And finally, I'd like to emphasize this report is not static. There's many, many layers of data beyond what we were able to include in this report. So our hope and intention is that this information will lead to new questions and the analysis, new questions and analysis that we'll access as our systems planning moves forward. So rather than bury the lead, we're just gonna bring out our summary findings here at the beginning, and we'll revisit them at the end once we've shown you all the data. So poverty in Travis County remains highest along the I-35 corridor. That means everywhere from Wells Branch going north to Runberg, St. John's, East Austin, Montopolis, and then Dove Springs. Really just hugging that spine of I-35 is where we find the greatest concentrations and numbers of poverty. In 2022, following the final counts of the current census, we're going to be carving up many of the census tracts that currently exist. And what that's going to probably result in is that we're going to have decreased counts in Pflugerville and Hornsby Bend. What I mean is those census tracts have gotten so large and so many people that they need to be cut up. And so when you break up those census tracts, you'll then have lower numbers of poverty. Proximity does not equate to access, and this is something I think we're gonna see a lot of evidence of as I present these figures. What we mean by this is areas and neighborhoods that have clinics also have some of the highest numbers of residents and patients not accessing service, whereas we have other areas, more suburban, that aren't close to a clinic, and they actually have some of the highest rates in numbers of people accessing care. And when we look at our poverty numbers, we're actually seeing enrollment is below what we would expect in areas such as East Austin, Montopolis, and the Leander, Jonestown area to the north, in the northwest corner of the county. The highest number of unserved residents, and this means the people that we've enrolled in services such as MAP and MAP Basic but aren't getting care, the highest number of those residents are in Runberg, St. John's, and Montopolis. When we look regionally, which is Travis County and the 6 surrounding counties, we see poverty is increasing. Highest, of course, in Travis County, but also in areas directly adjacent to the county. The low-income areas have the highest need for transportation in the county, and this is particularly true within Austin city limits as well as the northwest part of the county. Areas with high poverty rate. High poverty aligns with low numbers of employer-based insurance. And when we look at chronic conditions, essentially where we enroll the most people is where we diagnose the most people. However, when we look at the burden of disease, we see a slightly different tale. And when we say burden of disease, we're seeing prevalence rates. How many per 1,000 patients have a specific disease? And we see it significantly highest in East Austin and the Leander, Jonestown areas across nearly every chronic condition. And conversely, it's lowest in Colony Park across nearly every chronic condition. So the agenda, I'm going to go through the preliminary findings quickly that we presented in May, and then we're going to dive into some of the new information data sets that we believe really bring this report to a new level. As I spoke of, the burden of disease, prior to this report, the most detailed data we could present related to disease state of a population was counts by zip code. Unfortunately, this failed to provide us with much granularity. So now we look at what percentage of a population in a specific area has been diagnosed with a chronic disease. For example, we can now tell you exactly the rate of central health patients in Colony Park or Dove Springs who are diagnosed with hypertension and how that compares to the overall rate. As I mentioned, we've also got a 7-county poverty analysis. So we're going to be able to look at not just what's going on, what's historically happening, what we're projecting in Travis County, but also in the surrounding areas. And then we'll review the summary findings. I just want to do a little level set, but we're going to get into a lot of math here, and just want to level set with you guys what we're looking at. This report utilizes census tracts to identify population and demographic trends. Census tracts, they are designed, they're laid out by the Census Bureau, and they're designed to have a population between 1,200 and 8,000 people, with an optimum size of 4,000 people. So when you have areas like Travis County that are growing exponentially, what you have to do, and I was actually lucky enough to participate in this with Brian Robinson, is we have to sit down every 10 years and break up these tracts so that we can get them closer to that 4,000 size. Right now, there's 217 census tracts in Travis County, with the largest being East Pflugerville with 26,000. But due to that population growth and that we have to split them up, we're going to go from 217 to 290 when they release the new maps in 2022. And as we mentioned earlier, as a result of this, some of those census tracts that show up as having high concentrations of poverty now may not in the near future. Another thing to note is that starting in 2022, there will no longer be any areas within Travis County that are designated as rural. This will have some ramifications on funding streams for rural services such as CARTS, which beginning then will no longer be able to serve any areas of Travis County. So again, back in May, we reviewed families in poverty and how the trends had changed over time. If we look back to 2010, again, we see here's I-35, and we see the strongest concentrations are clustered along the I-35 corridor. The Runberg, St. John's, East Austin, Montopolis, and Dove Springs. We fast forward to today, and we've seen some new areas of increase to the north, which includes Wells Branch and this unincorporated areas to the south of Pflugerville. And we also see increases in the rural areas of both east and west Travis County. This includes Oak Hill and Bee Caves areas and the Jonestown area. Looking forward 5 years to 2025, the most significant changes we think will occur in West Travis County. This is Jonestown. It gets darker, meaning the families in poverty increases. West of 71, Oak Hill. And we're also seeing, these areas will actually be seeing higher numbers of poverty than these portions of the southeast portion of the county, which includes Creedmoor and Mustang Ridge. So we also brought you this map showing our total enrollments. This is MAP Basic, and sliding fee scale enrollees for 2019. And what it actually showed us was we're doing a pretty good job in areas of East Travis County enrolling people, especially relative to poverty level. What I mean by that is you see this area labeled Southeast Pflugerville. has a FPL, families in poverty, or FPL rate of 8.8%, which is below the county rate. But it's yet, so even though the rate of poverty is low, we're enrolling some of the highest numbers of patients in the county. Same for the county park area. Conversely, though, what this tells us is that there's other areas where we know we have high rates of poverty where we're not getting good enrollment, or as high enrollment. This would include East Austin here, East Riverside, Metropolis, and then areas of Runberg out here. We know this is the highest concentration of poverty, yet we only have one track showing up with high enrollment. The same goes for St. John's to the east of I-35. And in Dove Springs here to the south, we only have one track showing up, even though we know there's multiple tracks here with really high levels of poverty. This is the demographic breakdown of that population, that map that we showed you. So this represents the demographics of all of our math basic, and sliding fee scale enrollees combined together. If you look at age, most of the children here, under 18, these come from sliding fee scale enrollees. Only 7% of MAP enrollees are children. In fact, 88%, the overwhelming majority of MAP enrollees are between the ages of 18 and 64. So when you get those outliers, they tend to be from the sliding fee scale programs. Related to gender, pretty much across the board, the female population far outpaces our male enrollment. And then if you look specifically at MAP, the white, Asian, and Black populations all increase. So what kind of brings them down is that in sliding fee scale and MAP basic, 75% of the population is Latino. Okay, so now we're going to get back to the foundation of the demographic report, which is poverty. And that's how we show here is the areas we identified on the left, which was our 2017 report. And on the right, the areas we identified as having high and moderately high concentrations of poverty in 2020. So you can see some of the changes that are occurring here. In 2020 now, we've identified areas in Jonestown, Wells Branch, in North Travis County that weren't there before. But we also see some areas that are changing from, as you can see, they were more severe, the darker red. This is Pflugerville. Now it's turned to a more moderate level in 2020. The same can be said for Hornsby Bend. Goes from red to that more moderate level, and the southern portion of Colony Park goes more moderate. So once we identified those 40 or so tracks that had the highest concentration of poverty numbers, we went about separating them into 12 focus areas. And this allows us to analyze and compare the needs and the levels of services across the county. In the previous report, we had identified 9 focus areas. So in this report, those 3 focus areas came from, 1, identifying Leander and Lago Vista. We also separated Colony Park from Hornsby Bend as we grew to understand the unique nature of those communities. And then we also separated Pflugerville from these other areas in North Travis County. We did that because we realized these North Travis County areas were unincorporated portions of Pflugerville, Austin, and Manor, and therefore they didn't receive city services. We went through each of these 12 focus areas, and we provided analysis of the total populations, as well as our enrolled and served populations. And this allowed us to compare and contrast some of the differences related to enrollment and utilization. When we went through each of those focus areas, we developed these tables to help you understand the analysis. Where we identified central health funded, this was total enrolled population of MAP basic, and sliding fee enrollees. And when we identified central health utilizers, what this meant was what percentage of those enrollees were actually utilizing services. When we look at the next table down, what you see is the total population demographics. So this represents what is the demographics of everyone living in that focus area, whether they're a patient of ours or not. And the bottom table represents the demographics of our enrolled population within each of those focus areas. So what this allows us to do is compare and contrast what the total population was versus who we were enrolling. And I'm not going to go through all 12 of them like I did last time with you all, but I just wanted to kind of give a quick refresher of a couple so you can maybe remember how we got to where we are. So this was Colony Park. Again, this area to the south, the southern portion of Colony Park, this is Loyola Lane that bisects it. This area went from in 2017 being one of those higher levels of poverty to now a more moderate level. If we look at enrollment, Central Health funded, Colony Park actually has the highest enrollment of any of the focus areas that we looked at. So what this indicates is we're doing a very good job getting people enrolled in coverage in Colony Park. Looking at demographics, again, I think Colony Park is an area we know has a historically large Black population compared to the county at large. You can see Travis County is 8.3% Black, it's 22% Black in Colony Park. However, we contrast that to our enrolled population, where just 5.8% of the population, of the enrolled population is Black. So what this indicates to us is in areas, and we see this similar situation in Maine or in Pflugerville, in these suburban areas of the county, the Black population seems to be at a higher income level. Conversely, we see in Colony Park, nearly 87% of the enrolled population is Hispanic Latino. And surprisingly, that is the highest rate of any focus area throughout Travis County. And then we look at East Austin. Again, something changed from the last report, which was we added this Rosewood Chestnut neighborhood. This didn't show up in the last report. East Austin is it's got a moderately high poverty levels of poverty, but it's in a very concentrated area. And we believe that poverty and the need based on the housing stock in that area will continue in East Austin for the foreseeable future. As compared to Colony Park, what you see is that the demographics of the total population more closely mirror those that we enroll. For example, the total Latino population is around 58%, whereas our enrolled population is around, Latino population is around 63%. In the Black population, the total population is at 16.4, whereas our enrolled Black population is around 16%. The poverty, total families in poverty and the poverty rate, they closely match that of Colony Park. However, the rate of enrollment over here, this 11.5%, is much lower than Colony Park, as well as the total. So even though they have close to the same numbers of families in poverty, East Austin has less than half the enrollees. We also provided this analysis based on enrollment and utilization. What you can see on this table is that we have arranged these based on the total volume of families in poverty. So it goes from Runberg being far above the rest down to the lowest number of families in poverty, which is in Pflugerville. As you can see, some of these areas, East Austin, Colony Park, Del Valley, have relatively close numbers of families in poverty. As I mentioned before, when you look at enrolled population, Colony Park, Del Valley, they both have more enrollees than areas with higher numbers of people in poverty, such as Montopolis and East Austin. We then looked at what are the system utilizers. So that means how many of this population that we enrolled did we actually get into services. And then finally, we looked at the utilizer gap. So this is how many people did not access services that we enrolled. So as you can see here, we have by and large the largest gap, and the largest number of people were not getting into services in Runberg. And this goes back to what we mentioned, proximity does not equate to access. And this continues, St. John's, Runberg, these both have clinics in or adjacent to them. We still have by far the largest numbers of people not getting into services. But of course, this doesn't always track true, because there's areas with East Austin, for example, where if you're not enrolling people, then you're just not going to have much of a gap, because you're just missing even getting them into enrollment. So the following few slides basically present that same data, but in a more visual form. So these slides, this first slide, what this does is demonstrate total families in poverty. If you look at the white bar and the numbers next to it, that tells you the total numbers of families within each of these focus areas. So you can see North Travis County, which is that unincorporated area just south of Pflugerville, is by far the most number of families. However, if you want to look at the most number of families in poverty, we go to North Central Austin, which is the Runberg neighborhood. And you can see it's by far has the most families in poverty. In fact, only two areas, which is Northeast Austin, which is St. John's, and South Austin, which is Dove Springs, have even half as many families in poverty as the Runberg neighborhood. And again, as we mentioned before, if you look at County Park, Del Valley, East Austin, relatively similar numbers of families in poverty, as well as if you look at Hornsby Bend and Leander Lago Vista, Jonestown as well, they have very close numbers of families in poverty. So now we're looking at how many people we have enrolled in services within those respective areas. So the white bar, this represents the total population, and the purple bar represents what percentage in total of that population did we enroll in MAP, MAP Basic, or sliding fee scale. So look at County Park and look at East Austin. Again, when we go back, East Austin has slightly more families in poverty, but we look at enrollment, East Austin is less than half the enrollees. Like Del Valley, compare Del Valley has more than 200 less families in poverty. But there they almost double the amount of enrollees that East Austin has. And then we compare Hornsby Bend to Leander Lago Vista. Again, we go back, nearly equal families in poverty, but we've enrolled 4 times as many people in Hornsby Bend into services as we have in Leander Lago Vista. Also, if we look at Maynard Elgin has less than half the people in poverty as East Austin, but yet we've enrolled more people into services in Maynard than we have in East Austin. Also, as a reminder, if we just look at it as a rate, there's nowhere else in the county that we're enrolling as much of the population into services as a percentage as we are in County Park. So this is that utilizer number we were talking about. And this is what total and what percent of the population, total population we enrolled, actually access services. So again, as you can see, East Austin falls well behind Del Valley and County Park, areas that have less families in poverty than it, and people actually accessing services. And interesting enough, Hornsby Bend actually has the highest rate of people accessing services. So what we're saying is there's nowhere else in the county that we were getting more people that we enroll into services than Hornsby Bend. And conversely, when you look at Leander Lago Vista, there's nowhere where we're having issues even enrolling people there. And then once we do, we're not getting them into services. That has the lowest rate of enrollees actually accessing services. Okay, so now we're going, that was the review of what we looked at previously. Now we're going to start to go into the demographic report updates. We're going to dip into social determinants with looking at households without access to a vehicle. We have some insurance data that we want to bring forward, which will tell us about the employer-based, individual, and supplemental coverages within the specific focus areas. And then we're going to get into the burden of disease data, which includes the prevalence of chronic conditions and the total number of diagnoses. So as of 2020, the average focus area census tract had 125, or excuse me, the average census tract in Travis County had 125 vehicles without had 125 households without access to a vehicle. Compared to the total cumulative from our focus areas, which is 187. So not surprisingly, lack of an access to a vehicle affects low-income areas greater than affluent neighborhoods. This is particularly true in the urban areas of Austin. So now we break it down by focus area. And this blue line is the Travis County average. So you can see we've got some areas that are well above the average and some areas that are well below. And these are particularly the below average areas are to the east, the rural and suburban areas of Del Valley, Hornsby, Bend, Manor, and Elgin. Contrast that with areas like East Central Austin, and then the Runberg area, North Austin. And East Austin actually has the highest percentage of homes without cars at 13%, followed by North Central, which is at 12%. Whereas Hornsby Bend has the lowest percentage of houses without vehicles at 0.3%. There's two outliers to the trend, or kind of areas of concern, which would be Leander, Lago Vista, and Pflugerville, because they both exceed this county average, and they also lack substantial access to public transportation. And we know this is a particular challenge for the Jonestown, Lago Vista area due to its isolated geography.
This one, I think we could keep, we just have to think of language.
This is some of the new insurance data that we're bringing forward. And again, this is the combined all focus areas versus all Travis County. So as we can see, we have a...
Hold on, Jake.
Manager,
sorry, I'm hearing.
Yeah, if you don't mind, yeah. If we could ask everybody to please mute your microphones. We're picking up some feedback and some external conversations. Thank you.
Thanks.
Thanks, Mike. Yes, so as you can see in our focus areas, we have a lower rate of households with insurance. We also have, as we mentioned before, lower households with employer insurance. So low-income areas generally translates to lower numbers of employer-based insurance. And then we have higher rates of people buying individual marketplace plans within our focus areas. So again, we're going to break these down by focus areas. Leander has the highest rate of insured households, whereas Southeast Austin, which is Montopolis, has the lowest rate. Generally, as a trend, what we see is suburban and rural areas have higher insured rates than Austin and urban areas. When we look at employer-based insurance, again, what we see is it tracks with our poverty stats. The areas that are at or above the county average, Hornsby Bend, Leander, Manor, North Travis County, and Pflugerville, those are the areas with the lowest poverty rates. And then when we look at individually purchased health insurance, we see the inverse occur. The areas with the lower poverty rates tend to be purchasing less individual insurance plans: Hornsby Bend, Manor, Pflugerville. Okay, now we're going to be shifting to measuring burden of disease. And this is really an exciting new area that we haven't been able to measure before, not in this way. What we've done is we've geocoded all of the patients within our system who are experiencing one of the chronic conditions listed on this slide. We were then able to match them to their census tract, and that allows us to measure the prevalence rate per 1,000 patients, as well as the total diagnosed patients per focused area. So this is actually a preview from one of the pages in the report. Looks like it's page 57 here. And for each chronic condition, we reported the total number that had been diagnosed with that chronic condition. So here for diabetes, we have 12,091. Where they reside by census tract. So here we have the key. These darkest areas have between 152 and 328 patients diagnosed with diabetes. The demographics of the population that's been diagnosed with that specific condition, so the age, gender, race, ethnicity, and the top 5 locations that patients with diabetes visited during the year 2019, as well as the volumes, the number of visits within those specific locations. So of the 8 chronic conditions we analyzed in this report, hypertension, behavioral health, and diabetes have the largest counts of patients. Females represent the majority of patients for all the conditions, with the exception of renal failure. Regarding age, most of the patients are between the ages of 35 and 64. And Latinos are the majority race ethnicity among every chronic condition. Whites are the second largest portion in every chronic condition except diabetes, in which Blacks have the second highest number of patients. The top 3 provider locations that are visited are North Central, Southeast Health and Wellness Center, and Del Seaton Medical Center. Now, I'm not going to go through the total diagnosed patients of each chronic condition because we think that the prevalence rates, the rates per 1,000 patients, are a much better measurement of the burden of disease within a specific area. What we found, in fact, was that the number of patients diagnosed with the disease is closely correlated to the number of patients that we enroll. This is an example of what I'm talking about. On the left, you can see the map of where we've enrolled people within Travis County. And on the right, you can see where we have diagnosed them with diabetes. So on the left, the darker the color, the more people we've enrolled. On the right, the darker the color, the more people we have diagnosed. So as you can see, there's a close correlation between how many people you enroll in coverage and how many you then diagnose with a disease. So the issue with this correlation is when we see inequities in enrollment, such as what we discussed in East Austin and in Lago Vista, Jonestown. This can cause an artificial inflation or deflation of diagnosed chronic conditions, which is just based off enrollment. So you can see the pattern repeat itself. It's not always apples to apples, but there is a close correlation. We look at hypertension, we look at COPD. So rather than just focus on the total number of patients diagnosed, in this report, we have calculated the prevalence rates, meaning how many per 1,000 patients have been diagnosed with the disease. This measurement provides us a lens to view the burden of disease on a community, regardless of the enrollment numbers. So on these slides, the black lines represents the overall rates for central health patients, while the individual bars represent the prevalence rates for patients within those specific focus areas. So for example, with asthma, 44% per 1,000, or 4.4% of Central Health patients have an asthma diagnosis. And in areas such as East Austin, Hornsby Bend, Leander, Lago Vista, that rate is higher than the overall rate. And then we'll show you as well the maps that will show you the difference from what we looked at earlier, which is prevalence rates versus total diagnoses. For example, in the total diagnoses, you saw areas like Colony Park and North Travis County being the highest. Now you're seeing these other areas with much higher rates. Here we see for behavioral health, 15.4% of Central Health patients have a behavioral health diagnosis. In areas of East Austin, Lago Vista, they're experiencing rates near 20%. Again, you see these dark areas, meaning higher rates. For COPD, 4.2% Central Health patients overall have a COPD diagnosis. Most of the areas, most of the focus areas are in close proximity to that rate. The exception, again, East Central Austin, Leander, Lago Vista. You're going to start seeing some trends here as we go through this, meaning these two areas, as well as to a large degree South Austin, are going to be at or above that overall rate. You'll also notice that Colony Park in every chronic condition will be below the rate. The 10.8% of Central Health patients have a diabetes diagnosis. In East Austin, Leander, the rate's about 4% higher. In Dove Springs, it's about 3% higher. Here you have Leander, East Austin, Dove Springs. 2.2% of Central Health patients have a heart failure diagnosis. And this one, Pflugerville actually has the highest rate, which is the exception to the rule. This is the only chronic condition in which either Leander or East Austin does not have the highest rate. It's Pflugerville, Leander, East Austin. 18% of Central Health patients have a hypertension diagnosis. However, in East Austin, Leander, that number goes up to nearly 20, above or nearly 25%. So a quarter of patients in East Austin have been diagnosed with hypertension. This is overall the highest overall rate of any chronic condition. .6% of Central Health patients have a cancer diagnosis. Most of the focus areas are pretty close to this, with the exception of Leander, Lago Vista, which nearly doubles that rate. .8% of Central Health patients have a renal failure diagnosis. Again, most of the focus areas are close to that. East Austin nearly doubles it, and Leander, Lago Vista is much higher. Pflugerville actually did not have enough patients diagnosed for us to count it. We had to suppress it because there were so few. Finally, I want to show you this this heat map that Ashley developed. And this is actually the same data you just saw. It's just looking at it in a different way. So the columns here represent the different chronic conditions, whereas the rows represent those different focus areas. And what you see on this is the lighter the color of the box, the less prevalence disease there is in that area, whereas the darker means the more prevalence of disease. So as you can see, if you look at East Austin and you go across this band, you can see how dark it is consistently across the chronic conditions. The same goes for Leander, Lago Vista, much darker bands. And to a lesser but still significant degree, you see the same effect in South Austin, so which is Dove Springs, as well as Southeast Austin on top list. And you can compare this when you look at Colony Park, and you see a much lighter band for the most part across. So the question is why? Why do we see this in areas of East Austin, Leander, Lago Vista? I'm sure there's probably experts who can speak better this than I, but after speaking to some people about it, it's probably a combination of factors related to this. First being age. Leander, Lago Vista, and East Austin both have the highest percentage of age 65 plus residents of any of the focus areas. We also know within these two areas that we have issues with access to coverage. We've seen that both of those areas, East Austin, Leander, Lago Vista, they both trailed other focus areas with similar poverty levels in enrolling folks. As you remember, East Austin had much lower enrollment than Del Valley and Colony Park. And Leander had a much lower level of enrollment than Hornsby Bend, despite having near equal numbers of families in poverty. We also have challenges with utilization. If you remember, Leander, Lago Vista had the lowest percentage of enrollees that actually utilize services. There's also access to transportation. Both of these areas had higher than average households without vehicles. And we know that's particularly challenging for that isolated area of Leander, Lago Vista. And then there's also, of course, the area's issue of historical inequity. There's probably nowhere more representative of this than East Austin in Travis County, where they've suffered from generational race, poverty, and healthcare inequities. All right, I'm going to zoom you out now. We were pretty hyper focused there, and to kind of end this presentation, I'm going to zoom us back out and look at a regional look at poverty. We did this exercise to provide us with an understanding of patterns and movements of low-income populations that are adjacent to and near our defined service area. So we wanted to have a better understanding if or where, and should we be on the lookout that there may be unfunded low-income residents within proximity to us. For example, if there was high numbers of folks in poverty in Bastrop near our Travis County border, could they be coming and accessing services for clinics that we were funding? And what effect that could have on us. So beginning in 2000, as you can see, this is Travis County in the middle. Most of the high concentrations of poverty were clustered along the I-35 corridor. So remember, there's Runberg, there's East Austin, Dove Springs. There were some small pockets around Luling in Caldwell County and San Marcos in Hayes County. Another interesting thing we see is that rural poverty was largely absent in Travis County, whereas the rural areas of Burnett, Blanco, Caldwell, and Bastrop have much higher numbers of families in poverty. So by 2010, the region experienced a tremendous amount of growth in its overall population, as well as those living in poverty. The greatest concentrations remain in Travis County along I-35, but we start to see some increases as well in the eastern western portions of Travis County. Regionally, we're starting to see some increases in rural Burnett County. In Bastrop County, we see increases around Elgin and Red Rock. In Caldwell County, we see an increase just east of San Marcos, and in Hayes County, near Buda. So now fast forward to today, and we noticed in the past decade, we continue to experience increasing populations at all income brackets. Much of the areas bordering us to the east and to the west are now experiencing moderately high volumes of families in poverty. Hayes County, similar to Travis County, sees its largest increase along the I-35 corridor. To the north, Williamson County, however, is starting to mirror some of the affluence experienced in parts of Travis County. Looking forward 5 years, not that much change, not that many changes are projected regionally. Again, as we mentioned earlier, the southwest portion of Travis County will likely see some increases near Oak Hill and Bee Caves. We also see some increases as well in Hayes County, as well as this area to the in Williamson County to the west of Georgetown. And this gives you kind of the 20-year review of those changes. Okay, just to summarize very quickly with you, concentrations of poverty remain highest along the I-35 corridor. We see no reason to believe, nor do any patterns shown us, that poverty is leaving areas of Runberg, St. John's, Dove Springs, Montopolis. When we do this report next time, I would find it very likely if some of the areas such as Pflugerville and Hornsby Bend no longer show up because of the changes to the census tracts. We've seen proximity does not equal access. We have the highest number of unserved residents in Runberg, where we've got multiple clinics, St. John's, Montopolis, and Dove Springs. Whereas we have areas such as Hornsby Bend, where we have the highest utilization, the highest percentage of people getting into services anywhere in Travis County. Relative to poverty, we believe that our enrollment should be higher in areas such as East Austin, Montopolis, and Jonestown. Whereas we see very high levels of enrollment in areas such as Colony Park and Pflugerville. Again, highest number of unserved are in areas where we actually have clinic locations, Runberg, St. John's, and Montopolis. We see poverty increasing regionally, particularly in areas adjacent to our border. Low-income areas have a high need for transportation services. As you remember, the highest need for transportation services was actually in the Runberg neighborhoods, which, as we just mentioned, also has some of the highest number of unserved residents. This is particularly acute in Austin and Northwest Travis County. High poverty rates align with low rates of employer-based insurance. So again, those areas in the suburbs and the rural areas where the poverty rate's lower, they tend to have higher employer-based insurance. Chronic conditions align with total enrollees, and the burden and prevalence of disease is significantly high in East Austin, Lander, Jonestown. Conversely, it's significantly low in Colony Park. And with that, I'd be happy to take any questions.
JP and others, all I can say is just amazing, absolutely amazing. You guys did a fantastic job. And so I'm going to open it up for questions and comments. Manager, Chairman Greenberg, you have a comment, and then I'll get to you, Manager Valadez.
Yes, I do. And I cannot begin to tell you how fabulous this information is. Every time it has improved. You know, when I first got on this board, we really did not have this kind of information. I immediately, and Cindy started asking for, we need the demographic information. We need the demographic information. There was a significant improvement last time. And JP, you remember, and Mr. Giesland, that we went to Commissioner's Court and presented there, and it was very well received. But this is just a whole nother level. And I want to thank all of the people who were involved in putting this together. I know some of you here are appearing on the matrix, the screen in front of me, but many are not. So please thank everyone. Number one, are these slides available to us now? And number two, when will this report be available to us and to share with others? Those are my opening questions. Thank you.
Yes, I believe the slides are available. I believe they went out and backup, but yes, they are public
But
now.
I mean, can we share these? They're shareable, right? Was really my question. If I could get these in a way that they could be shared, that would be, I think, wonderful. If that's okay at this point. And then I cannot. I can imagine the amount of work that's going into putting this report together. When do you think it will be available?
I'm hoping by the end of next week.
Wonderful. Thank you. Thank you. Thank you.
Wow, that's amazing. Thank you. Manager Valadez. You're on mute, Manager Valadez.
Thank you very much. You don't know how long we have been asking for this. I know I have since before my Central Health tenure. But thank you, Sherry. And thank you, JP, and all your team. You're to be commended. And you're to be commended because you're going to be providing the data that will help develop so that Central Health can implement and develop strategies to be able to overcome some of these big gaps, especially with the number of families living in poverty that are not enrolled, or if they're enrolled, they're not accessing services. We need to get on top of it. And the only way I can see us doing that is through outreach. So I need to make sure that I push that again, because I think where you are succeeding is where you have sent outreach teams specifically, like into Colony Park, into Hornsby Bend, into Del Valley. I don't know if there was any people sent into Runburn specifically, or Dove Springs, but those are reasons for us to consider doing that. Okay, so as we're looking at transportation problems also, the city is pushing us with Project Connect, and that's gonna take up a lot of valuable land that are high poverty areas already struggling with. So are we working with Capital Metro to collaborate with them in transporting our people who are still going to be left in those areas to access clinic sites? And also with Capital Metro specifically on the other areas like in Runburg, where they do have a transportation system, and maybe creating routes that the Runburg residents can actually go to a clinic or to the HEB in. I think that's an important conversation that we need to have with them, because I never see Capital Metro at the table. Maybe y'all are talking to them, but I never see them. And that's an issue I would personally like to emphasize with them. Because proximity doesn't equate to access, are we really creating barriers by these systems not providing transportation for our patients to utilize the clinics? Or are we having problems elsewhere with maybe the keeping of appointments, the making of appointments, the managing the patient demand, that kind of thing? I think that you're providing us a lot of food for thought and ability to look at how this data can help us look at strategies that we can use to make improvements there. And with respect to an outreach plan, if one is being developed, I'd like to know how long it'll be before we see the boots on the ground. And one last thing that I didn't see any demographic information to was for the ethnicity and rate insurance or uninsured, whichever way it goes. I didn't see a slide that represented that, because I saw your employer-based insurance, I saw the other insurance. I did not see demographic data on who has insurance and who doesn't. Or I didn't see a question that addressed the job or jobless issue. And I think that's key to everything that would be, that we would have to address with respect to the social determinants of health, of life, and resources. So I remember having this conversation, Sarita, maybe it was with Lydia at Community Care when she came and made a presentation to us about the questionnaire, the surveys that they were going to provide. I asked, why is do you have a job, not the #1 question? And she says, well, they had already developed the survey, but they would consider it. Well, I think it's a required question of anybody that we try to get information from. So I'd like to know where we are on all of that.
Okay, would JP, and I see Manager Jones's hand. I thought I saw Manager Musaita, but before we move toward that, JP, did you or Monica want to address any of Manager Val's questions?
Well, I appreciate your comments. I'll speak to a couple of these things. Transportation, at Sherry's behest, we've actually convened a healthcare and transportation working group. It doesn't have any official charter, but pre-COVID, we were meeting in person regularly every 2 months. Really kind of trying to expose each other to a better understanding of each other's systems and needs. You know, we have run multiple transportation pilots, and I think if anything, we've discovered we are not in the transportation business, nor should we be, but there is significant need, and there are improved outcomes when we do provide those services. So yes, we have begun that, and we will continue in that, and Cap Metro has a lot of exciting new programs going. They have a pickup program that we'd like to see in new areas. It's basically an on-demand shuttle program. They're doing it in Manor. We worked with the county and Cap Metro. They actually launched a new shuttle program in Hornsby Bend. So it's you know, from what I've learned on transit, it's hard to do and it's incremental. But we are at the table together having these discussions with them now. Regarding your question about insurance and then by race, we purchased a data set from Claritas, and that data actually was not broken down to that in that way. So we would have to look for some different sources. I can tell you, and Sriya could probably talk better this, if you go to the census tract level, once you keep splitting things up, the data just becomes less and less reliable. So if we were to look at this one specific census tract in East Austin, and then break it down by race and ethnicity, and then break it down by insurance status, the number would start getting so low, we couldn't really tell you if it was accurate or not.
Okay, thank you.
And what about the other questions?
Which one?
With respect to jobs, the question of asking whether they have a job when they complete a survey.
JP?
It's real simple.
If I could jump in on that one, please. You know, I think if I understand your question, that's really a function of not only patient intake, but also perhaps other surveys and discussion guides that are used at the clinical level. And I'm not able to see everybody on the matrix, but if somebody from the healthcare delivery side of Central Health or on the CUC side can speak to that.
Another reason I ask that is because that income level is what determines whether they're eligible for MAP or MAP Basic.
Right. Jonathan? Mr. Morgan?
I'm sorry, Dr. Bell. I think I missed Manager Valadez's question on the jobs and the surveys. Could you restate that portion of your question?
Yes, Jonathan, with respect to the surveys that are providing the information and the data, that we're using to develop so that we can make analysis and develop strategies and plans is the question, which should be the first question to be asked, do you have a job? Is that anywhere on there? Because I can remember when community care came to us or someone came to us and made a presentation, we were still meeting in the training room. So it was that kind of a meeting. I asked them, why do you not ask the question in the survey? And that goes to everything with respect to eligibility, with respect to ability to provide for themselves, et cetera, et cetera. If they don't have a job, they don't have a house, they don't have this, they don't have that. Okay, so is that question asked anywhere? It's a fundamental question and core to everything, everybody's quality of life.
All right, thanks. John?
Yes, sir. So I think it depends on the survey. What you're looking at here is a combination of multiple data sources and multiple types of surveys. Some of those surveys are things that we develop and have the ability to insert additional questions like the one that you're describing. Some of the surveys are standardized national tools that in order to keep the statistical relevance of those tools, we have to administer them in a certain way. But for the surveys that we complete internally and that community care completes internally, I think that's a really good recommendation. I don't think in the survey that we administer for patient experience and quality of life, those are two national-based survey tools that we follow a standardized form. But I think there is an opportunity for us to add additional questions. I don't think either of those address employment today.
Okay, so when we're trying to make someone eligible for MAP, when we're somebody trying to make them eligible for MAP Basic or whether or not they're sliding fee scale, when you ask what is their income, is it income due to what? Do you have a job or are you selling drugs on the street? I mean, we need to know specifically, because if we're going to be looking at terms of social determinants of life and the data that we gather talking to our partners in the provision of that quality of life, then with respect to jobs and job training, those are things that should be core or integral to the conversation.
Again,
So
I think it's a great conversation. Just a quick response that when we are going through an eligibility screening process, we are looking at income and we are looking at employment for individuals. So we have some of that data related to those processes, but that may be separate from some of the surveys. But it is data that we can pull in.
So with respect to JP's demographic report, especially when we're talking about MAP Basic, and SFS, then I'd like to see that data. And I'd like to see it broken down by ethnicity.
But Manager Valdez, if JP doesn't have and JP, don't let me speak for you, but if those data sets aren't there, then is the committee recommending or asking or directing staff to amend this demographic report?
Do you need for me to justify this? Because
No,
I will.
No, I just need direction from the committee about what to do with the demographic report.
I think it's real simple and necessary. And if we have it through community care, we should be able to get it.
Okay, Manager Greenberg.
I certainly understand your desire, Manager Valadez, for this very important information. May I make a suggestion, which would be, given the amount of extremely valuable information in this report, as you have noted, for us to analyze and chart our path forward, particularly either getting people enrolled or getting utilization areas where we aren't, and coordinating with our transportation work group that we have, that we go ahead and get this report completed. It was noted that they thought they're pushing, I think it's a hard push them, for the end of next week. And then also after that, see if it could be amended with additional information. Would that meet your needs, Manager Valadez?
Only if I knew that they were seriously going to incorporate that data if it is available.
Well, yeah. I think what I'm hearing, Manager Valadez, is that first of all, they need to look to see if
I know, I understand.
All right. I mean, there's been a lot of theories as to where it is. All right. And then you've got to make sure that it's valid. All right. So that's going to take some work. But let's go forward with what we have now, and then we can really work on it.
Right, and that's what I was suggesting.
That, but the only reason I'm bringing this up is because it's not been brought up. Today is the first time you're hearing this. I have brought this up today, but before, and to tell you the truth, when we're talking about a systemic overhaul or improvement and working with other entities and groups for resource opportunities, I think that we have to have that information, especially as we could go to the county and tell the county, hey man, where's your job training program? If we're not following the trends that are necessary to employ people here in Travis County.
Agreed.
Okay, thank you.
Did you have something to add?
Yes, and I think it's that we're hearing about two things. One is about joblessness and figuring out how, one, do we collect the information on joblessness? Is it accessible? Is it some way that we can synthesize it today? And that, absolutely, we will look into where that's gathered and see if we can synthesize it and pull it together. And if we don't have it today, then we'll figure out a way that we can get to that moving forward.
Monica, you're a lifesaver. Thank you very much. And JP, I thank you for that excellent report. Thank you.
And then I think the second question was on ethnicity and
insurance
disease burden. Oh, ethnicity and insurance. And one of the things I just want to make sure with JP is there is information that is part of building the charts and the data that got presented in the report that we can access to do additional deeper dives into reporting for you as managers to answer questions and help plan. And I don't know, JP, was that something that was available that's just not in this presentation, or is it something that you guys hadn't been able to look at? And if you don't know, Sarita, is that something that you can answer just right now?
Insofar as breaking down insurance by ethnicity, I'm not certain. We got the data from Claritas. I'm not certain those data were broken down to that level of granularity. But again, the numbers start out being so small. Once you start breaking down by census tract to the specific demographic population that those patients belong to, those numbers can potentially be misleading because they become so small. They could be volatile, right? So you might see in this month or looking at the data, you might see in this quarter that this census tract has this percentage of this population of Hispanics who are insured, and then you look at it at the next quarter, and it's a totally different area. That there's a shift, right? And you don't want to be led by numbers that small. It just will drive decisions that aren't made on sound data.
Thank you, Sarita. The issue is that we have historically, since we began ACA in 2010, we've been given numbers about at least 30%, or the Latinos are the highest uninsured population in the state of Texas. And in Travis County, there was an assumption it was 30% or more. And if wherever that information lies, maybe we should refreshen it. But I'm assuming that during the data that will be received by the Census Bureau in 22.
And we may, I'm sorry, we may be able to get to those numbers at that larger scale. So Travis County wide, yes, but not at the census tract or neighborhood that we're looking at.
I appreciate that because I'm preparing for legislative action, and I've got other things that all related to the health and the quality of life of our patient that I'm getting.
Thank you, Manager Bell.
Getting prepared for.
I appreciate it. Thank you. All right, Manager Jones.
I think Manager Masaita was before me, so I'll let her go first.
Manager Masaita.
No, you can go ahead, Mr. Jones. I'm fine.
Okay. All right, then I just have some yes and no type of questions, if you don't mind. And I appreciate the opportunity to allow me at least half of the time that Manager Valadez had to get my questions answered. The first one is, Is this data that you referenced to, and I'll compliment you, you did a great job, it really was fantastic. But I have some questions about the source data. So are we using census data when we're talking about some of these numbers with regards to changing in populations and demographics?
Census tract level data we purchase through Claritas, which is an independent research firm.
And is there data, do they use the same source as the American Community Survey to update data, or is this, how recent is this data, I guess is another way of asking that question.
Yes, from what I understand, they use ACS data, and then they have proprietary formulas that they apply to that to develop projections.
Okay, my concern is that until we have the census data, I have real concerns about the reliability of their models for what's occurring in these areas. And so I'd be very cautious of us putting a lot of faith in that information until we actually have some validation from the census. I understand we have to do that in order to make projections, but what we've seen in Travis County over the last 10 years is a significant migration out of Central East Austin. And I noticed a lot of your data refer to East Austin, and I certainly understand we have some significant issues still in Central East Austin. A lot of that is tied, of course, to the homeless population. But Central East Austin has also been impacted significantly by gentrification. And my concern is whether or not that reflection is in the data, because many of those are individuals who were in Central East Austin are now living in Dale Valley, Colony Park, Manor, Pflugerville. And if the data is not reflecting where they are now, and we're making projections based upon that, I have some real concerns. So that's just a comment with regards to the source of data. The second thing is that you made this, I want to make sure I'm understanding. Are you saying that populations in suburban areas of the county outside of Lago Vista are basically in good condition health-wise? Because what I heard particularly is in the Eastern Crescent, Colony Park, parts of Dale Valley, Manor, that there's no issues out there. And one of the reasons I say that is because we use the data, I guess, from our current population. Did we assess the APH data to determine or ascertain whether those populations' outcomes, overall population, not just ours, are really as good as they look in the data that was presented in the Eastern Crescent piece? And so that sort of concerned me as well. And then finally is, particularly as it relates to African American, I need to be able to, what I'm hearing you say, oh, there's no problem. African Americans are doing great. I don't think that's also a true assessment of the current picture of the African American health status in the community. So I'd be interested in how you would assess that in light of increased mortality and morbidity, particularly as related to COVID and other chronic diseases.
So, Manager Jones, I can address those questions if you will. Regarding the assertion that those communities are in Hornsby Bend or are doing better, are doing well or are fine, I don't believe that's what this presentation is really saying. What this presentation is saying is relative to all of the communities that we looked at in these focus groups, those areas fare better than the other ones. Again, we're looking at our specific prevalence rates among our specific population, and you're starting, the geography sort of goes out the window a little bit and maybe won't be exactly the same as what you may see in an Austin Public Health map. And the reason for that is because we are limiting our population to those who reside in Travis County who are below 200% of the federal poverty income level. So that in itself will have bearing on that chronic condition, that population's tendency toward acquiring chronic illnesses over time, right? So poverty, age, all of those things contribute to that developing chronic illness. So if we're already looking at an income level at a poor population, then again, whereas APH is looking at everybody in Travis County, you will see that map where there's a higher concentration of poverty, look darker in those areas east of I-35 than you would see, west of I-35. So again, it's that population that's being examined, looking at all of Travis County versus looking at only those in Travis County who are below 200% of FPL. And that's where I think those differences are in what you've been seeing.
But that data is,
and that is,
I'm sorry, just saying that data you ascertain from our own records. Is that right? You're not.
That's correct.
So those populations are in and out of those income levels all of the time. You have people who are working and then they lose their job and they're back in poverty situations. So making those assessments, and that's what's happening in these suburban communities, is that people go in and out of those situations.
Sure. And just so you're aware, we are looking at disease going back in time. Like, we capture these patients, their chronic illness at any time that they presented in the system. So we try to get that comprehensive look. So even if they left the system, came back into the system, if they were part of that population of our enrolled population in 2019, they would be accounted for. Their disease, that disease burden that they contribute to, they'd be accounted for in that disease burden calculation. Does that make sense?
I hear you. I just think hearing what I just heard today leads me to believe that there's not a problem in Eastern Travis County for people who are 200% of poverty or below. That's what I heard, and I may be wrong, but that's just what I heard. So that's why I made the comment.
Okay, Mr. Giesland.
Yes, and let me just reiterate and sum up what Sarita just said. But we're not. This report should not be interpreted by anyone to suggest that we can check the box in certain areas or in certain communities or communities of color. That is not what this report says. In fact, it does point to areas of varying need, but there are still some unacceptable, especially if you think about disease prevalence that are out there, that through our systems-based approach, we need to very aggressively go after and tackle these issues over the next, we've been doing it, but really ramp up those efforts in that regard. But thank you for allowing me to make that commentary. I appreciate it.
Thank you, Mr. Giesland. Okay, Manager Musaiti, and then Manager Oliver.
Thank you. I appreciate it. Well, before I move forward, I just needed to ask, Sarita, thank you so much, and your team. You've done an incredible job, and I commend you on your efforts. Just a question related to the denominator of the data with APH and Travis County. So is your denominator different?
APH hasn't reported on prevalence rates that I've seen in quite a few years. So we would have to, see what those updated numbers are. I know that there were some reports that were published a couple of weeks ago, but I need to get to the actual source data to confirm those numbers. But I would imagine that the denominators are very different. If Boston Public Health are reporting the entire census tract or the entire zip code, actually they were doing it by zip code is what I remember, than what we're reporting.
So that probably brings out the discrepancies between probably the data we have and others.
Right.
Well, thank you. One thing, I just wanted us to continue on following the data. And I know it may not be as what we expected it to be. That's why we have the data to guide us to where we need to be and what issues we need to address. In terms of the, as I'm talking about the data, the timeline period, what was it? And I know we haven't collected these census for 2020. The data that used, what was the timeline? I'm just curious about that. do you have it?
Our patient data, so all the MAP basic, all
What
the
period
chronic
of
condition
time?
data, that was
For what
2019,
period?
Fiscal
FY
year.
2019.
Okay, so it's fiscal year. Great. And my other question is, and perhaps Dr. Bell may be able to answer me. Now, in terms of utilization, what is the ideal utilization of services that, because I looked at our, we haven't really, I think the highest was in the upper 50 range, but in general, like insurance coverage and other providers, what do they expect and desire to be the ultimate utilization of a program?
Well, did you say Dr. Bell or did you say Dr. Schulze?
I said Dr. Bell because Sendero. I'm just trying to, as a payer, as utilizers.
My thought about that is, my ideal utilization is 100%.
Well, true.
Because in essence, I'd like to see everybody receiving healthcare. But I know that's not true. It never has been true in the populations that we've worked with. So as close as we can get to 100%, the better off we are.
So wonderful. So with that said, and given the data that was just presented, I think it opens the opportunities for us to reach out to those communities who are below even the 50th percent, like we've that has been outlined. So that's really the issue, the gap that I've noticed, that we need to go out and do more outreach in those communities to increase the utilizations of our services. So that's really the point that I was trying to drive, and thank you. In terms of transportation, and know the and maybe our lawyers can probably intervene here. Is it within our capacity, and knowing the urgent need of transportation, to support Project Connect if it really fulfills the need of transportation for our community? So that's the legal issue. Just wanted to ask you if it's within our purview.
Are you asking financially?
Not financially, even like.
Okay. I mean, a statement in support that I don't see that there's anything that's an issue of jurisdiction in that. But when you get to financial support, obviously that's something we'd have to look at, and I'd rather not, without a lot of preparation and a lot of research and the ability to brief you all in executive session, I'd rather not just opine off the cuff on that.
Well, thank you. I think it's something that we should probably consider, given that transportation is a barrier to our community, and it's a barrier to access to health. And a project it's ongoing right now in our community. Maybe perhaps if we even put our name behind it. Again, it's all about based on what legality and what the board as a whole agrees to do and move forward. My other final question is in terms of predictors. Now, you used other chronic illnesses. Why wasn't obesity a predictor? Because obesity is a big predictor of other chronic illnesses, such as, everything like you've outlined. So to me, I think that would be a better assessment, because it leads to others. And now when we're trying to address the social determinants of health and obesity, we know that we have food deserts, we have lack of connectivity between these communities. So it opens our eyes on how we can better serve and improve the health overall outcome of our communities who are in need of our services. So that was really just a highlight over what I will dig in deeper, and hopefully I can sit and connect with Sarita and your team for further clarifications. And again, I want to commend you on your effort and time with this report. Thank you.
Thank you very much.
Dr. Bell, if I may just address one last question of Manager Musaitov's.
That'd be perfect.
The question regarding obesity, so capturing those data, getting those BMI is a little more difficult because we don't necessarily have those specific data elements available to us, but it is certainly something that we can start capturing in our clinical data set that we receive.
That would be great.
Excellent.
Thank you.
Manager, I see you, Manager Valadez, but I want to get to Manager Oliver first, please.
Thank you. And yeah, thank y'all for doing such incredible work. But I did notice it didn't address a lot of the why behind it. And I know that's probably a much bigger project to tackle, but eventually if we could maybe get some, why is it that in, the Leander Lago Vista, it looks like their, cancerous tumors are twice the rest of the population? Or why is it that there are no cars or households without cars or vehicles are so high in certain areas? So I think that would be helpful. I know that's a huge project and I would not expect y'all to undertake that and get us back results anytime soon. But with respect to what Manager Valadez was speaking to about employment, I would find it interesting to see if we ran a current day, what is the population that is employed versus, obviously we're in a pandemic where millions of people have been laid off versus what it would be normally. And I know that's probably difficult to capture because you're probably asking when somebody's filling out an intake form and maybe once a year, maybe updating it, so I don't know how you gather that information, but just something to think about. And I know we don't have a lot of a population that's over 65, but considering that we do have some, I would assume that most of the folks 65 and older would be retired, but that's just an assumption. I know there are 65 and older folks who actually do work, but just considerations, that's all.
Thank you, Manager Oliver. It's funny, I had the same question with regard to the why and how. And I think I've asked that to Monica. They are going to sort of do some analysis and come back to us and sort of outline the possibilities of what's going on. Like you see that there are people that are not enrolled that should be enrolled in certain areas. The burden of disease is greater in some of these areas than others. You're right, it's not an easy task to do, but it's something that we have to look at and at least get some handle on and try to make decisions going forward. So great question. Monica, did you have anything to add to that at all? No? Okay. Manager Valadez.
Thank you. Let me find. Okay, thank you. I remember to unmute myself. The only reason I brought up Project Connect in relationship to Central Health was because I wanted to know whether we had had any conversations with the city and with Capital Metro to see whether or not they were going to be, as they often displace people with respect to accessing right-of-way in order to build these things, and they're mostly impacting people that are poor. If you look at the maps, whether or not we have talked to them in terms of whether or not they can provide these kinds of services as accessibility and transportation from the people who are still going to remain in those areas impacted to the clinics. That's what I wanted to make sure that we could do. So Sherry, that's one thing for your committee, and not for us to get involved of supporting or not supporting other entities' projects that are going to require tax rate increase, et cetera, et cetera. I don't think that that's our role. But I do think that having conversations with those entities that are people we can partner with and should be partnering with to provide those services to our patients, our consumers, is most important for us to have before we can ascertain whether or not a project is worthy. So thank you. And with respect to the jobs or joblessness, the only reason that's an issue to me is because every application that I have ever had to fill out for all the hundreds and hundreds of people that I have helped, that's always the issue, the number one question. And are you employed? And so I think that that's important for us to have and start acquiring that data. Thank you very much.
Thank you. Chair Greenberg, did you have something to add, please? You're muted.
Yes, just in response to Manager Valadez, perhaps, and I know that JP and others are so overworked, but we could have another meeting of the transportation working group. Beyond that, Manager Valadez, I know that there is funding and that the city council has not set the agenda item yet, but it is forthcoming very soon as far as the ballot language and the exact items. But I know there's some money that is included in Project Connect that would be, for instance, for displacement and gentrification, to mitigate that because of times when you see with transit-oriented development increases. So I can see if I can find out more on that, and perhaps we can reconvene that transportation working group. Beyond that, I think these are excellent questions that everyone has posed. Some people may know that one of my favorite comments in track changes or in writing is why. So yes, but there's not necessarily an easy answer. And I appreciate what Sarita said on some of the data. If your number is too low, then it may not be significant. We have to watch out for things like that. And it will take some time to get to the why. There are correlations, there are causations, and we may have to bring others in. But thank you all very much.
Thank you, Chair Greenberg. Manager Musaitis?
Thank you. And there's also confounders as well. Now, I just have a question, actually more of a comment. When you're releasing this document, if you can at least have a disclaimer, because I know that there will be some questions arise with what Manager Jones have addressed and concerns that perhaps one population is better served, just to better clarify it. So for the lay audience who were not part of this discussion can understand. So I just don't want to cause any misunderstanding of the data. So just a simple outline of the why and all that. Thank you.
That's an excellent suggestion. Mr. Giesland?
Yes, thank you for recognizing me. And I appreciate that, Manager Musaitis. And I think back to what Manager Jones was asking, his question, and then the other questions that you all have raised in comments have provided us, and I think I can speak on behalf of all staff that have touched this report, with some insight about how people look at this report and the conclusions that they draw. And I certainly think it allows us to explain, take another stab at how we explain things and how people interpret results and the conclusions. So this entire conversation has been incredibly valuable. And I thank each and every one of you for your questions and comments.
Chair Greenberg, please.
Yes, sir. My assumption is that, in fact, the report will do all of that. What we saw was a slide deck, and my expectation would be that in a report of more than 70 pages, that we will have a 2-page executive summary, that we will have robust discussions and explanations in that type of report. But I do think that this has been, as Mr. Giesland said, a good kind of trial run. It's always good to have, in addition to the executive summary, the 1-pager of bullet points, the 2 pages, the 5-minute slide deck, the 15, the full-blown, as we've seen here, plus Q&A that you're going to expect, and even some role play. So I'll just leave those thoughts with you.
Thank you.
Thank you, Chair Greenberg. Monica, did you want to add something?
Yeah, just briefly also, that just making it clear, thank you all so much for your feedback, and also knowing to make it clear, the areas of focus are our areas of focus. There are areas of highest need that have been identified, not just for now, but also we see these as being high need areas moving forward into the next 5 years. We can add some explanations about the Claritas data set, where that comes from, how that data is updated, so that people understand where we're getting the data from, why we're looking at, our mission-focused population in some of these areas, and then also really highlighting that these 12 focus areas are areas of need. None of these focus areas are, that there could be no implication that any of these focus areas are okay or fixed, or that, we've rung the bell in any of them. There still are focus areas that we are committed to improving care in and improving services in. So,
Manager Jones.
Yeah, will we be able to get, once the report is completed, a bound copy that could be made available to each manager? So we'll have to print it out or have it electronic. I'd like to be able to have a bound copy of this.
She's shaking her head, so I think they
Yeah, so we'll try to get each of you, if I can just throw this assignment out there, try to get each of you more than just one copy, because we realize you have conversations with people that you consult with, and certainly want you to be able to share this information. Very important.
Okay, I have Manager Valadez, but hold on. Manager Oliver, did I see your hand? No? Okay, Manager Valadez.
Mine was just going to be real quick and feeding off of Sherry, the scientist over there, the citations, you know, so I'm looking at an old high school paper that I had to submit, or a college paper that I had to submit. So when you do, I would assume that we're going to have the citations. And if you have the index or appendix or whatever, if you can make sure that you have the link so that people themselves can go look to those entities that are providing the data. That might be a good thing too. We don't have to provide everything, just give them a link at least to the citations for where the data came from. Thank you.
Great suggestion. Chair Greenberg, did you have a comment?
I'm sure, yes, that there will be the appropriate citations, of course, and whether it's just citations or they have sources, we can look at that. But beyond that, I think one of the things that I've heard from the group, from the managers who are present with their excellent conversations, a theme I've heard is context. That it's very important to make sure that we provide in a way that's understandable to people the context, whether it's the citations, whether it is that all of these are focus areas, they all have need, and the context, I think, is very important.
Excellent comment. Manager Musaiti?
I definitely agree with you, Manager Greenberg, well, Chair Owen. One thing that I hope that we can have in the report is discussing about the power size and something to imply towards that, and the validity and reliability of the questionnaire that was conducted. I think that will address also some other questions within the public. Thank you.
Thank you. Any other questions, comments? This has been an excellent discussion. I think we have really gotten a lot of information out there. I think that the staff can understand how people now sort of interpret that report. It's funny because I sort of interpreted it the same way that Shannon did, and the fact that it did look like Colony Park, everything was okay there. And we know that that's not the truth. Right. And so we need to be able to make sure that the public understands that our focus areas are these areas, and they all have significant problems, and that we want to make sure that we address as much as we can in each and every one of those areas. So, okay, thank you. And I would like to lay out agenda item number 5, receive a report from the Eastern Crescent Subcommittee on items discussed during the August 12th, 2020 Eastern Crescent Subcommittee meeting. I don't think that Chair Jones has anything to report, but I will turn it over to him.
No, I have nothing to report. It's basically that we went through the items identified and had a very good update on the COVID-19 testing location, and updates on the location for our planned facilities out there. Other than that, there was no real major action requested to go forth to strategic planning, so I have nothing else to say, really.
Thank you very much. And the Eastern Crescent Subcommittee meeting was quite interesting also. A lot of really good discussion. And finally, before I can lay out agenda item number 6, I would like to thank all of the board members that are not appointed to the Strategic Planning Committee who attended. I really appreciate your attendance. I hope that you found it valuable to listen to the discussion and to provide input. I know your time is very valuable, so I thank you. Agenda item 6, confirm the next strategic planning committee meeting date, time, and location. Managers, our next regularly scheduled Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, September 9th, 2020 at 1 p.m. or following the Eastern Crescent Subcommittee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment. Manager Valadez, you're on mute. I have a motion for Manager Valadez.
I'll second.
I have a second from Manager Musaitis. All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned. Thank you, guys. I really, really appreciate it.
Thank you very much, members. We appreciate it.
Thank you.
Great job.
Thank you. Wonderful job.
Great,
Wonderful job,
great.
everyone.
Thank you all. Thank you.